morning. I, Dr. Somu, would like to welcome you to the Pediatric Neurology Workshop. It's a part of Eastern Journal Neuropedicon. This is the third one and the fourth West Bengal Neuropedicon. Our chapter is a bit still in the infant stage. It has started just 4 years back during the COVID period, and it was the initiative of Dr. Chidi Banerjee sir, who took the initiative to form this chapter. Gradually, day by day, we started to believe that we have to develop the subspecialty. Otherwise, we will not be able to pinpoint. Say, in my clinical experience, I have seen cases that which were not diagnosed years back, or there is some doubtful diagnosis, but subsequently with the development of subspecialty chapter, we have been able to pinpoint it and we have been able to make a more rational diagnosis treatment. Now, gradually, this is the first time we are having a workshop on neuroradiology. It has been found that neurology and immediate radiology, they are very closely related. And without immediate radiology, neurologists are more versatile. Just I am sharing a small story. After passing MD, I was practicing in a rural area. It's Bangna, where after giving a typhoid vaccine in the year 2008, just immediately I passed out. I gave a typhoid vaccine. After that, a child lost vision. Just you can imagine how pathetic the scenario, and I was scared whether I will visit the place again or not, because already they have started putting a lot of pressure. I went over the literature. Is there any side effect of typhoid vaccine where there is loss of vision? Nothing. Now they went into RIO. At that moment, RIO was very much, still RIO is a very much respectable institute for ophthalmology. Even at RIO, they failed to find out the truth. Now, you know what happened after that? People go to either LD Prasad or CMC fellow. They went there, and I'm telling you, even at CMC fellow, sorry, LD Prasad, they treated the child, but they couldn't pinpoint the diagnosis. They just given methyl prednisolone after that. If you go to the chronology of neurology, you see that many diseases where NIMHANS or EMS or even CMC fellow, particularly refractory epilepsy or accumulative diseases where they couldn't pinpoint the diagnosis, what they do, they give IVIG or methyl prednisolone. When I was working as a RM at Midnapur Medical College, whose faculty was present there, my close colleague. Now, I found that children used to admit at Midnapur Medical College in the year 2010 to start off. They used to come and take a IVIG once a week. And what is it needed? Refractory epilepsy, nothing more than that. Coming to this child, now I'm telling you, what is the diagnosis? It was a case of optic neuritis, which is a type of, you can see the type of edemos, which was not diagnosed in the year 2008 or 9, between that period. But people should perceive that this kind of problem, if I can understand, you can give IVIG or methyl and get it. Because what happened? At that moment, people were not well conversant with imaging radiology. It is imaging radiology which helped you to diagnose cancer. But for the last 5 or 6 years, there is a significant improvement in the MRI, in the imaging field, as well as our clinical concept. Now, in most of the cases, we have been able to make a proper diagnosis. So, with this introduction, I would like to start the presentation. Today we are having total 7 sessions, of which the last one, that is describing the white blood disease. Speaker is Dr. Nirmal Raj, renowned interventional radiologist. Due to professional reason, he will not be able to present, but he went to Northeast India for professional reasons. But he sent me the presentation in a video format that will be played at the end. It's a long one. There are several sessions, so I will start my session very soon. And first of all, the disclaimer is that I am a pediatrician, not a radiologist. So it is just an introduction to why MRI, imaging radiology is important and why it is necessary. And I'd like to thank all of you. I'd like to say the respected IIP President-elect, Professor Shapul Rai, and also Professor Malakar, both of them are present. So with their permission, I am starting the session. So you know that better than true that your eyes are useless when the mind is blind. So what we are going to speak in the next few minutes is just a 30-minute session which includes around 30 slides. The neuroanatomy, which is the basics which you know prior to imaging medical stage. Then the modality of imaging, the basics and the normalization. The normalization is very important because if the difference is not converted that to the MRI or CT of a newborn or infant, which looks exactly like the aging population. So they might think that it will be a sequencing of HIV, someone is going to go down. And during the era of age infant meningitis, which the junior doctor said, there are a lot of effusions, subcortical effusions as a part of meningitis. Sometimes it is considered that there is a subcortical effusion meningitis, but I think that gradually evolving by myelination period. So this is the brain. Now human brain that is divided by means of the central surface into two parts, the frontal lobe and parietal lobe, and there is also the occipital temporal lobe. Now this is again divided into various lobules by means of sulci, and there are gyri. The sulci and gyri that is able to give the huge brain, having a lot of neurons, billions of neurons in the small space of cranial bone. These are the broadband area of the brain. Basically, it's a functional. The areas of the brain have been listed various numbers, which are distributed various functions like the frontal area, like the visual cortex, the visual cortex. This one should know prior to interpreting the brain image. Cross section of the brain is the medial surface. Now, if you go to the medial surface, you see the lobes. The lobes are nomenclated according to the cranial lobe. There is a part which is in the frontal lobe, is called the frontal lobe, which is the temporal part, the temporal lobe. Now, if you go to the cut section, you will see that there is presence of various lobes like the frontal lobe, parietal lobe, occipital lobe, and also there is the lateral ventricle, the third ventricle, the corpus callosum, which is connecting the two hemispheres of the brain. There is pons, medulla oblongata, and the cerebellum. This is a very busy slide where the names of the important pons of the bone. Like there is the corpus callosum, there is the lateral ventricle, there is the hypophysis, which is there just above the optic valve. And here there is the pons, the cerebellum, and also the various lobes of the brain. Now, this is the actual anatomy. If you get the image, this is the equated MRI. If you see the image, then you will see how it looks like. If you similarly spot the gray matter, the white matter, the gray matter is the outer, the inner is the white matter, the thalamus, the body of the corpus callosum, and this is the caesar. Now, caesar comes widely into the images. Either will come 1:1 and 1:2. There is a caudate nucleus, parts of the basal ganglia, which is an important center and which commonly gets affected in the center of the remains. There is cerebellum, the vertebral artery. This is how the image. So if you compare to the previous one, this is the actual picture and this is the image how it comes. And how to radiologists report? They actually see what is the normal intensity, normal contrast of the picture, and whether there is more intensity or less intensity by which they can interpret whether there is a lesional, whether there is inflammation, whether there is a stroke-like event or an issue or frank blood hemorrhage. This is the circular release, a very important blood supply that is of the brain. Now, when this is blood from the important sources, that is the internal cavity artery above, the internal cavity artery above, and there is a ventrovertebral artery. Now you see that both the vertebrae they get united on the ventricular artery. This ventricular artery again divides into two posterior cerebral arteries. And there is internal cavity artery from where arises the middle cerebral and the anterior cerebral. Now the two anterior cerebral arteries they are communicated by anterior communicating artery, and there is a posterior communicating artery which connects the internal cavity with the posterior cerebral. This forms the circular release. This is closely related with the thalamus, and also if the blood supply is such that if there is obstruction in any part of the brain, the other people are. So if you want obstruction, the posterior supply will maintain the regular part. Because brain requires the highest oxygen demand, and you cannot wait for few minutes also. By that time there will be hypoxia and there will be irreversible damage to the brain. So nature has provided in these ways are arterial circular veins. This is the picture of the brain or the table which are being supplied. Just you see that anterior cerebral artery they are supplying mostly the upper part of the frontal lobe, also this part of the parietal lobe. But if you see the cross section, you can see a number of parts like it will supply the parietal lobe, supply the part of the temporal lobe. Next is the middle cerebral artery, which is mostly supplying the lateral part of the forebrain, and also in the inferior part of the temporal lobe, and the posterior cerebral artery, it is supplying predominantly the occipital lobe. This is the, you can say the MR arteriogram, that is how the arterial circuit, arterial circular release and what is their territory of brain that is supplied. Now here there is anterior cerebral artery which has two segments, A1 and A2. Basically A segment is the part it supplies from the internal cavity artery to the anterior communicating artery. And the A2 segment is from the anterior communicating artery to the medial aspect of the cerebral hemisphere. So any event at the A2 or the A1, be it the hemorrhage or the occlusion, it will give a corresponding picture in this way affecting the parts of the brain. Then you go to the MC or the middle cerebral artery. It also has two segments, the A1 and A2. The A1 segment is from internal cavity artery to the bypassing of the Sylvian fissure. And the A2 segment is the again divided into two parts, one is the superior and the inferior division, and in this way supply the parts of the temporal lobe. So any event in the M1 or M2, M2 is there, you will get similar picture. In this way, see, the result is enabled to say that which part of the artery were blocked. And coming to the PCA or the posterior cerebral artery, it is the P1 segment is from ventral artery to the posterior communicating artery, and the P2 is the posterior. So first part is supplying the middle, and the second part is going in the deeper parietal. So if there is a problem in the A1, so medial portion of the frontal lobe got affected, and strokes here lead to the contralateral limbness. You know that at optic chasm there are external fibers right to the left right interface. And if there is a problem with the A2 supply, in addition to that you have a urinary incontinence, personality changes, and this occurs with the involvement of the frontal lobe. Coming to the neutral and the length-to-study artery, it supplies the basal ganglia. Basal ganglia is an important part of the brain, which is the center of accession of all the motor and the sensory activities. Also, it supplies the anterior lobosacral capsules. And stroke here causes contralateral hemiparesis and dysaxia. Now, lenticular striatal artery is supplying the basal ganglia and the capsule. So these two arteries are predominantly concerned with supplying of the basal ganglia parts of the brain. Coming to the middle cerebral artery, which has the M1 and M2. M1 supplies the lateral control, the temporal, the parietal, and a stroke event will cause a contralateral hemiplegia, aphasia, and hemianæsthesia. Similarly, M2 will affect the Broca's area and the inferior division. You know, inferior has the two parts. it will causes warning aphasia and also visual cutting. The P1 supplies the occipital lobe, the inferior temporal lobe, and the deep ganglions, and any event here will cause the homonymous hemianopia, and P2 has a similar supply. These are the veins. The veins of the brain are a bit different because it doesn't follow the artery. In other parts of the body, whatever coronary artery, like say there is a femoral artery, femoral vein, but you will not get here in vein. What happened? The nature has given there are various sinuses. The sinuses are basically nothing but the pleural reflections. And to protect it, most of the sinuses they are separated by pores. Like see the superior sagittal sinuses, but not the inferior one. Inferior one is lying at the free margin of the falx center. So inferior sagittal sinuses and the straight sinuses, they are not supported by the bone structure, but the superior sagittal sinus, the sigmoid, the transverse, the pectoral sinus, and even the cavernous sinus also, they are all supported by the bone structures. So they drain out all the blood from the brain and they are ultimately put into the internal jugular vein. This is a picture and this is a venogram which shows. Now if you see this picture, you see that which are the places most commonly involved. Like the superior sagittal sinus is the most common place for thrombosis, followed by the transverse sinus, which is the incidence of about 41-48%, then internal jugular vein and the other like cortical veins, deep veins, and also there are sigmoid and deep venous systems. Okay. Now, this is schematical presentation of the basal ganglia, one more important structure you have to know well. You see that basal ganglia is composed of the claustrum, the lentiform nuclei, caudate nucleus. Now, this is an important structure of the internal capsule which divides the caudate nucleus into the head and also into the posterior limb. This is what actual picture. So this is what is actual picture and what it looks like in an you could note it that there is a claustrum, there is a tail of the caudate nucleus, there is head of the caudate nucleus, globus pallidus and putamen. The ventricles of the brain, they are another important structure. This is some cavity of the space in the brain which harbors the CSF. The important are the two lateral ventricles. They are located in both the cerebral hemisphere and they are attached by foramen of Monro with the third ventricle and the third ventricle links via the aqueduct of Sylvius, the fourth ventricle. Now, aqueduct of Sylvius, it is the narrowest part of the ventricle communicating channel, which is just about 2 to 3 millimeter, and that is the place of commonest obstruction, both during embryogenesis or even it could happen due to some inflammatory process. This is the lateral picture of the vein, which shows the lateral ventricle, which are the again parts like anterior horn, the body and the posterior horn. Then it drains into third ventricle, and this is the fourth ventricle. Third ventricle is related to the thalamus and midvein, and the fourth is related to the hindvein. So ultimately it enters into the central canal of the spinal cord. Now, this is the minimum anatomy you should know about it. Definitely, you have to go, radiologists have to go much depth to know all about it. Now, next part is the modules of the neuroimaging. The most commonly used is the CT and MRI, and both the CT and MRI has their own advantages and disadvantages. Now, if we say the important point that CT has the advantage that it's a very rapid process, it do not require a longer time. But there are a lot of disadvantages in the CT, like there is an iron radiation, which is a very damaging effect. You cannot perform in many cases. Secondly is that other than bone, the rest of the structures like the fat, like the CSF, like the muscles, everything are very much well visualized in MRI. Now MRI can take a multi-color imaging without changing the patient. But for CT, you have to constantly change the table of the instrument to take a picture. So it's a problem for someone who is under respiratory support. And CT has the advantage that there is no claustrophobia, particularly in pediatric population. Very often I get a problem that the center is not well converted center performing MRI. Just yesterday, a center in our Pihala, State Pihala, they refused because the child required CT IVU. They couldn't do it because only centers who are handling the pediatric patients, they are able to perform this sequence very good. And you have to first sedate the patient, that's very important. This facility is not river. So claustrophobia is a very big problem with MRI, but it's not a problem with CT. And also patient with cochlear implant and using an MRI and those of them is complementary MRI, you cannot do an MRI. So CT is the only help. So there are definitely advantages of CT and MRI. Now in a CT, how it looks like? The bone, the calcification and the middling object, they are brighter. And for any bony lesions, the CT is the best. Now acute blood that we commonly see in cerebrovascular accident, it looks like white. And subacute blood like this. So if somebody have a cerebral hemorrhage, if you do it immediately, you may not get a complete information because it takes 2 to 3 times to get that bright white light. Now muscles are very poorly visualized on CT, and the gray matter, they looks light gray and the white is the median. So coming to the MRI and its images, now the physics behind the MRI is very complicated. CT, X-ray, they have a similar type of mechanisms, and ultrasound uses the Doppler sound effect. But the technology MRI is totally different from all these three. Because MRI requires, how it works? It requires a strong magnetic field, and in the strong magnetic field, when you are putting a patient, what happens? We have protons, that is the positive H+ ions of water in our body. And these protons, they are in an Chapel-like position. Now once you put them in a strong magnetic field, these protons take a polarized position. So just like you think what happens, we have seen in physics that if you put a magnet, all the iron nails will take the direction toward that and will take a proper position for the polarization. Now initially MRI does this polarization. Then we apply a strong radio frequency to dismantle this polarization. So again all the protons, they become disorganized. After that we withdraw the radio frequency, and again the protons take a normal polarized position. So during the process they throw signals, and these signals are captured by the sophisticated computer and they create the images. So that is why MRI is able to differentiate muscles from fats and fluids with CSF or blood. Now how long you are throwing the radio frequency and how much this make the difference between T1 and T2 images. So let us discuss this slide first. The T2 weighted images, they have a short repetition time as well as a time to echo. Whereas the T2 weighted images, they have a longer tier and a longer T. So in general, if you want to differentiate between T1 and T2, it can be differentiated with CSF. CSF is always dark in T1 and bright in T2. This is an easy T2. Now there is one more sequence called the flare sequence, which is commonly prescribed. Just for example, let's say that why it's important for you to attend the neuroradiology. Suppose you are thinking somebody can have a epileptic seizures and you want an MRI. Then you should never forget to write the MRI epileptic protocol. If you write the epileptic protocol, then only the technician and the radiologist will use the flare sequence, as well as they will take a very thin slice of about 2 millimeters. Or else, if we don't write the history properly, you put the radiologist in the dark, and also there occurs inappropriate interpretation because he or she is not seeing the patient. So flare sequence is fluid attenuated inversion recovery that is similar to T2, but it gives a very prolonged T and PR. And CSF is again made dark here, and the abnormality is like, say, any pathology or any SOL, it becomes bright. So just you see the time seconds. This is all milliseconds. In T1 we use 500 microseconds and T is 40. Whereas it becomes 4000 in T2 weighted and 9000 in flare sequence. So how it look like? So if you go to the slide, you can see that we have given a comparison of T1, T2 and flare. In T1 weighted, the CSF is dark. In T2 it is bright, and in flare again it made dark. In white matter, we have to get a light in T1 weighted, whereas dark gray in T2 and dark in flare. The cortex is uniformly more or less gray in all the sequence, and the fat is bright in T1 and the relatively less bright in T2 and flare. And inflammation appears dark in T1 weighted and T2 and flare becomes bright. So this is a very important practical notes for you, by which you can at least think about what's on T1 and what. This is about the spinal cord, again the T1 and T2 comparison. As usual, CSF is dark, CSF is bright. The muscles are grey and with a deep grey, dark grey. The spinal cord looks grey and gets light grey because spinal cord has a lot of grey matters. And the fat similar. So things are more or less similar, and inflammation, it becomes more bright in T2 and less bright in T1. This is the MRI of T1, T2 and the flare sequence. Here the white matter is shown as green, the grey matter is yellow, and the CSF is a bit like grey. So CSF is dark, grey matter is grey, and white matter is white. Here the CSF is bright, grey matter is grey, white matter is darker. And in flare it is more or less like T2, only the CSF becomes darker. These are few advanced MRI sequence. Just you know the name, like GRE. These blooming effects, these are basically used to find out pathology, like microblade in the cortex or a small SOA. This sequence I will not go into detail because there are new radiologists, they will discuss in the details. Just you get familiar with the terms. Now, gadolinium is a contrast which is commonly used in the MRI, is very safe, and you see how by applying the gadolinium we are enhancing the bright signals in the blood vessels. And this is an important slide, like what are the preferred imaging procedures in neurological diseases. It's taken from Nielsen. Most commonly we get the ischemic infarction or the transient ischemic attack. Here basically CT perfusion, if possible, can be done. If the patient is unstable, MRI is definitely the best. We will subsequently go for both MRI and MRI angio. In any ischemic or any event, commonly ischemic injury is more common compared to the hemorrhagic injury in pediatric population. We have to go for this MRI angio in same sittings. If it is an interventional hemorrhage, then it is less than 24 hours, then CT, and if it is more than 24 hours, then MRI, because MRI takes time to pick the signals. In case of AV malformation, CT scan for acute hemorrhage, and MRI without gadolinium, because this is hemorrhage, that's the reason. In cerebral aneurysm, again, the MRI is the most important diagnostic modality. In hypoxic ischemic brain injury, even you can pick the sequelae as early as in the neural period. In the neural time, in addition to the USG, MRI is a very strong predictive value of what will happen in the subsequent part. So MRI is definitely a very good investigative procedure for cases of lumbar asphyxia. All for metabolic disorders, we require the MRI. In almost everywhere you see MRI is the most important diagnostic modality, except in head trauma. Head trauma, we usually go for CT. For brain tumor, for patient epilepsy, in all cases we have to go for the MRI, and also recently PET came for noting the activity. This is some of the slides which show how the section is taken in actually and how it looks like. This is an axial cut to the superior frontal parietal region. This is through axial cut to the these two same, just in different level. Now this is the basal ganglia, how it looks like. Here lies the third ventricle, the lateral ventricle, the caudate, the lentiform nucleus, the anterior temporal lobe, the sigmoid fissure. These are the important points which may get in the exams. The midbrain, the fourth ventricle and the pons, this is to the foramen magnum, and this is the last part, a little bit of normal myelination of the brain. This is very important in pediatric field. Myelination begins in the fetal life and it continues till 2 years of age. It progresses from caudal to cephalic direction, central to peripheral, dorsal to ventral, and sensory before motor. The structures which will get myelinated at birth include the posterior limb of the intercapsule, the middle cerebral peduncle, dorsal ventricle, ventrolateral thalamus, the perivalent gyrate, pyramidal tract, and optic pathway. It is best appreciated in infants with T1 weighted, and after that, from 1 year onwards, the T2 weighted images are very good for modeling the level of myelination. Any myelinated structure looks hyperintense or bright on T1 and it is dark on T2. By 3 months, anterior limb of the intercapsule and the splenium of the corpus callosum. By 6 months, the genu, and by 8 months, the subcortical matter gets myelinated. If myelination is not developed, then you have to think of hypomyelitic disease like the Pelizaeus-McGregor disease, the Cockayne syndrome. And if myelination gets delayed, say if splenium of corpus callosum is not myelinated by 6 months of age, then definitely it's a type of delayed myelination. So to level it, we have to go for serial MRI scan at the interval of 6 months. And MRI is very safe, though it's a very troublesome and cumbersome process for the newborns, but it is definitely safe compared to CT. This is a picture of a normal newborn T1 weighted MRI. If you are not the age of the child, you may think some pathology is there, but it is a normal. And these are the sequence, like term, 4 months, 6 months, 12 months, 1 year and 2 years. So just you see from 1 year to 2 years, they become near normal MRI pictures, just take a balance. So the take-home messages are, hold the scan plate before seeing the report, because you may find something which others may miss. And always help the employees by giving clinical reports, because it is not possible for them to see what is happening to the patient. And do not get blinded to the black and white. And oral investigation when it is necessary. Just like say, whenever there is a first episode of unprovoked, no requirement of going for a CT or MRI, no requirement, because this can be the only event in the whole life. And most of the epilepsy, you get nothing in the brain. So with this I am ending. Thank you. If you have any query, you can ask, or else we'll move to the next session.
The time he is setting up the computer. Good morning everyone, I'm Dr. Sudesh Shah. I'm consultant in radiology at Apollo Multi-Speciality Hospitals, Kolkata. And I'd like to thank Dr. Jashodhara Chaudhary and Dr. Shomshubhru Bose for inviting me as a faculty. So yes, it's very important that our clinicians should know a bit of radiology. It really helps. So we're not that kind of people who don't want you to know radiology. It really helps, and the whole talk today is basically focused on that part. The part of neuroimaging of a pediatric stroke that every clinician should be aware of. Because as we are all infamously unavailable at night, after evening hours, we're always having our coffee. So you better understand your radiology so that you don't always need a radiologist on call. Okay, so I believe most of my audience is residents. So what is a stroke? What do you understand by stroke? So anybody of you can just stand up and start answering. We'll make this interactive. This is not a radiology question, this is a clinics question. What is stroke? Anyone? No one? Okay, fine. So, stroke is basically when suddenly the blood supply to a part of the brain is cut off. It could be arterial or venous blood supply which has been cut off, and it results in certain clinical manifestations which you people are very well aware, and it is known as stroke. So stroke is a medical emergency, and that's why this topic is very, very important. What are the clinical presentations of a pediatric stroke? Now this is your question, you have to answer this. So anybody? Yes, you were saying something, no? I don't know that. I don't know how a pediatric stroke looks like, because when the patient form comes to me, it has already a diagnosis made on it, that likely stroke. So please tell me how you diagnose stroke in the emergency. Say it's a 2-year-old child. Yes, sir, please.
It's very uncommon in children population, but nowadays we can see some strokes in different age group of people. We start from the newborn also. Newborn, you can have strokes also. In the toddler stage, you can see the limping, some dizziness, some unusual behavior, babbling of sounds, not usual behavior, sudden unconsciousness. So these types of things we can suspect strokes. So in that case, we order for this case and send to the
So yes, the work is a little difficult here for the clinician, because as an adults we all know there is hemiparesis. We've all been taught one side of the body will stop working and you know it's a stroke. But unfortunately in pediatric population where they can't even stand and walk, diagnosing a hemiparesis or a unilateral limb palsy is sometimes not that easy. So kudos to the clinicians who make the diagnosis of a clinical pediatric stroke and send the patient to us for imaging. Right? So this is just a pictorial representation, not very relevant in the pediatric population. Carotid disease is not one of the causes of pediatric stroke, but just to put how it is, the sudden blood supply to the brain is cut off. Now the magnitude of the problem is not as minute as you would think. Stroke is still the 6th leading cause of death in children, affecting 2 to 13 children per 1 lakh population under 18 years of age. The diagnosis is often delayed or missed, as we have all discussed right now, because the symptoms are non-specific. And certain etiologies of pediatric stroke are unique from the adult population, so we will have a different approach on how to go about with stroke. Now again, there's an exhaustive list. I'm sure all your textbooks have these lists. So let's just discuss some of the common causes of pediatric stroke that you know. Again, I would like some answers from the audience. Anybody at the back? The last case of pediatric stroke you saw was due to, in the emergency while you were practicing. Yes, I can hear some murmurs, but nobody is loud enough. Yes, very good. So heart disease is a very common cause. Anything else? Yes. Tubercular meningitis, very common in our country. So obliterative end arthritis leading to strokes, very common. Anything else? Yes, very good. Sickle cell anemia, very nice. And? Scrub typhus, yes. Yes, so we have all listed the common causes. I will not get into the details of the table. They have been properly classified into vasculopathies. Then where the artery is, underlying artery is at fault. So this is the list, the exhaustive list you have all mentioned. Then it could be the prothrombotic states as correctly stated, and cardiac disorders, very nice. So cardiac disorders again is a very common cause. Sometimes it's the genetics which is involved. So you know the mitochondrial disorders which present as stroke-like episodes. And infection, very common in our country, tubercular meningitis, and COVID-19 had also presented to us with few cases of pediatric stroke. Now as we have discussed the epidemiology of the disease, now what are the types of stroke that you know of? So whenever the blood supply to the brain is cut off, it manifests as either a ischemia, that is the brain, the part which blood supply has been cut off, or there may be a manifestation of bleed. So it can be ischemic or hemorrhagic, and this is same for adults as well as pediatric population. So ischemic is by far the more common cause. So whenever we see a case in the emergency, most commonly we see an ischemic stroke. Again, ischemia can be caused by the blood vessels supplying the brain. So what are the blood vessels? It could be either an artery, it could be either a vein, or sometimes both are fine, but it's just a transient ischemic attack. So we have already discussed the arterial and the venous supply of the brain in detail. I will not get into the details of it. So this is exactly the pictorial representation which you saw, the venous sinuses drainage as well as the arterial supply to the brain. So it can be cut off at any point and it will lead to a stroke. So now coming to the imaging modalities. So we all know there are two tools that we have, that is CT as well as an MRI. So CT and MRI, we have also discussed in the previous section that which is better, which is not. But let me put it very simply for you. So when you need a fast diagnosis, like you're in the emergency, it's like 2 in the night, there's a child with possible stroke, you just want to rule out that you're not dealing with stroke, CT is your best modality because there's nothing as fast as a CT. The modern helical scanners that we have today can finish a CT brain scan within less than a second. So CT is what you ordered in the emergency. However, if there's a child who is presented in the OPD with very subtle signs, like a seizure or maybe an abnormal behavior, and it's not an emergency, you don't diagnose it in the emergency, then MRI is what is better because it gives us more information about the type of stroke, the etiology of stroke, and helps us further decide on the further management of stroke. So when you're asked this question in the exam, what to do? So you say like if it's a fast diagnosis we need, it's a CT, and if you want to detailedly evaluate, it's an MRI. So again, CT, we do 2 types of CT for stroke. So one is a plain CT, which you all must have ordered at some point of time, and then there's another which is CT angiography. So CT angiography is what? We inject contrast and we track the vessels going into the brain, which is the arteries predominantly here, and we evaluate whether there is anything focally abnormal with the arteries or not. It's something like a real-time angiogram, but obviously less invasive and faster. This can be done in the emergency. So it is slowly becoming the new gold standard for imaging in ischemic strokes, because you always cannot shift a patient to a cath lab in the emergency. So discussed the cause, obviously there's a lot of ionizing radiation, but the risk-benefit ratio needs to be calculated. Whenever you have a patient in the emergency, you have to weigh your risks versus the benefits in ordering a CT. And most of the time, the benefits have been found to be more. And it is okay to ask for a CT in a child without overthinking about the fact of ionizing radiation. What is definitely in favor of CT is the widespread availability. So every emergency in the hospital in the city almost has a CT in place, so you can always get a CT done. The speed. So the fast scanners that we have, they will finish the scan within less than a second. So most of the time you won't even need sedation, which is again a very limiting factor in pediatric population. You have a child, so you can just tell the mother to feed the child will fall asleep, and you can finish a CT scan in the sleep without the need of sedation. And obviously CT is very sensitive in detecting hemorrhage. So as nicely discussed, in cases of trauma, you don't go for an MR, you directly go for a CT, or in the stroke setup, you have to rule out a hemorrhagic stroke. So if you order a CT, you can clearly differentiate between an ischemic as well as a hemorrhagic stroke. Now, before I move on, so let's just see, we discussed a lot of neuroanatomy. So again, I would like anyone from the audience to spot the abnormality here. So this was a child presenting with some hemiparesis. I will not tell you the side because then you'll apply your pediatric knowledge and diagnose. So, which side? This one? This image? Okay, so what is happening here? Yeah, I do agree there's something going wrong. There's something wrong here. So are the images projecting clearly at the back, or we can have the lights off? Because radiology images are best seen in the dark. You must have seen your radiology suits all dark. Can we have the lights off at the back of the hall, please? So yes, this was the area of abnormality here. So just as a red herring, this was a normal CT scan, and very nicely you identified that this is an area where the grey-white matter differentiation has been blurred. Can you make out? So that we cannot identify where the grey matter starts and where the white matter ends. There is effacement of the sulci. You see the cortical sulci are well delineated here, whereas we do not see the sulci here, so there is some edema, there is some abnormality going here. So this is exactly how an acute stroke looks on CT. Okay, so these are the subtle signs you have to look. You have to look for asymmetry in the sides. So whenever you are in doubt that which part is abnormal, you have to start comparing. And one good thing about the brain is you always have a normal contralateral side. So you can always compare, So it's not like a bilateral disease so that you will get confused. So yes, this was an acute infarct in the left frontal lobe. Another sign that we often see in the emergency is the dense vessel signs. What happens is, so this is your middle cerebral artery, this is a plain scan. So please be careful, this is not a contrast scan, this is a plain scan where this middle cerebral artery is not well seen, whereas this middle cerebral artery on the left is looking more bright, it's dense. So why is that happening? So clotted blood is white on CT. So this middle cerebral artery has something in it which is clotted and not the normal flow. So we identify it as a dense MCA sign. Usually more commonly seen in the adult population. In pediatric patients, we don't have like a full MCA getting blocked. It's usually the smaller branches, M2, M3. But do look for these hyperdense vessels on a plain CT scan. Often you have patients of dengue in your emergency who are dehydrated. They may also land up in these kind of thrombotic episodes. They may have sinuses thrombosed, the venous sinuses may be thrombosed, or the arterial supply to the brain may be thrombosed. So look for any abnormal white on a plain CT scan. And now this is a short video of how a CT angiography looks like. So this is, we've given contrast here, so this is the contrast CT. And if you identify, you have to trace this. This is the area that we are tracing. This is the vertebral arteries here. This is the internal carotid artery here. And now we are going to trace it into the brain. So we go up, and it is almost as good as an angiogram. So this is the basilar artery now. This one is the basilar artery. This is the cavernous segment of the internal carotid artery. And this is the area of the circle of Willis, the bifurcation, the middle cerebral artery on both sides, the anterior cerebral arteries, the posterior communicating artery, the basilar, bifurcating into the posterior cerebral artery. So this is exactly how a CT angiogram looks like. So it's okay if you cannot interpret a CT angiogram in your emergency, but you should have an idea of how it looks like. So this is a very nice modality for picking up aneurysms, AV malformation, which may be an underlying cause of a pediatric stroke. And also in cases of ischemic stroke, you can identify the area of the obliterated vessel or the thrombus, which can be then further managed. So hemorrhage is very easy to identify on stroke in CT. So the moment you order the CT, the plates come to you. You just have to see is there any white on the film or not, because there's normal CT brain should not have anything white within the brain parenchyma in a pediatric population again. So every word I said here is important. In an adult population, sometimes you may have calcifications in the basal ganglia which may look white, and we often have our clinicians coming to us saying that is this a bleed? But then it's symmetrical basal ganglia calcification. Most of the times you people don't have to worry of seeing something like that, because pediatric patients will not have basal ganglia calcification. So anything like this in your patient CT is abnormal until proven otherwise. So now coming on to the next imaging modality. The imaging modality of choice in stroke is an MRI, both in pediatric as well as adult population. So you don't get confused. When we want to fast diagnosis is CT, but imaging modality of choice in acute stroke is MRI. So why is it so? So what happens is the management of stroke changes depending on at what time the child has presented to us in the emergency. So the MRI is able to characterize the duration of stroke. Even though you have a symptom, you have the parents telling you a history that probably the child had started having symptoms 2 days back, but it may not be always very reliable. Maybe the parents noticed it late, or they don't exactly remember when the symptoms started. That's where your MRI comes into play. It is going to exactly tell you a time frame of the stroke that the patient had. So we've already discussed the basics of MRI. The first sequence that we usually have a look in an MR of a brain is, in cases of stroke, is the diffusion weighted sequences. And the sequence which goes on complementary with the DWI is the ADC map. So it's simple, you have to pick up again anything white on diffusion, which is black on ADC. Okay, so it's very easy. So you see this area is white on DWI, and this is black on ADC. So this is representing a true diffusion restriction. Anything which is white on DWI and not black on ADC is known as a facilitated diffusion, and that is not something you're worried about in the emergency. You're worried about something which is white on DWI and dark on ADC. So you understand what diffusion restriction actually does, or what it actually signifies? Yes, I can hear somebody saying. So the basics of diffusion restriction is that it is seen that in normal brain parenchyma, which has normal water content, the water molecules are moving in free Brownian motion. So it's all physics, So Brownian motion is there in the water molecules in a normal brain parenchyma. The moment the brain tissue infarcts or it dies, what happens is the Brownian motion is restricted, or the free motion is restricted, and that is what the diffusion picks up as a bright focus. So whatever is bright on DWI is representing the brain which is already dead or infarcted brain tissue. And the same logic also applies when we are seeing diagnosing diffusion weighted images for tumors. So anywhere where the motion is restricted, as in cases of hypercellular tumors, there will be diffusion restriction. So the basic physics is same. The application is different depending on the pathology you see. So in stroke, remember, whatever is bright on DWI and dark on ADC is the area of the infarcted brain. And this is what appears very early in stroke. Within 6 hours, we start picking up these areas where the CT will be absolutely normal, and every other modality will say everything is normal, but MRI is going to pick up this area of diffusion restriction. So we see they say 19, but it's less than, from 6 to 7, 8 hours we start picking this up. And then obviously as we go, the pattern of the imaging changes. The diffusion restriction will decrease, the ADC blackness will decrease, but the other sequences will now start picking up stroke better. So what happens is, for acute stroke it's DWI, and for late subacute strokes you have to look at your T2 and FLAIR images. So now here comes a very important concept, which is the concept of penumbra. So whenever a blood vessel to the brain is blocked, there is some tissue which is more vulnerable and it dies immediately. That is known as the infarcted tissue. Whereas there are some parts of the brain around it which still have some collateral circulation left. They are not dead yet, they are ischemic, or they are the tissue which is salvageable, which is still not dead, and that is salvageable. And why is it important to know this area? So we will just discuss one modality of MRIs. People keep telling us that we don't have colors in our lives, it's all black, grey and white. So that's when we started inventing these newer modalities in MRI, which is perfusion weighted MR. So perfusion weighted MR detects this area at risk, which is the tissue which is still salvageable. So what you see here is, this is the diffusion restricted area, which is the dead tissue, and you see a larger area of abnormality around it, which is the area which is still ischemic, not dead yet. So this is known as a diffusion-perfusion mismatch. And whenever something like this exists, we say that these are the patients who are going to benefit from thrombolysis or thrombectomy. So whenever you are referring a patient for thrombectomy or thrombolysis in the emergency, it is good if you can determine this first, because that will determine whether your procedure is going to be effective in the long run or not. Because the already dead tissue is never going to recover. A brief preview into the role of intervention radiology. Dr. Nirmalo, our speaker, he's an expert in this field. He's a neurointervention radiologist. What they do is they make a very small hole in the groin, insert a catheter, go all the way up in the brain, and that's how they remove the clots from the brain when the patient presents to them within 6 hours of stroke. So that's what is the golden period for stroke. So if you've diagnosed the stroke within 6 hours, you need to call your intervention radiology. They need to take a call whether there is a lot of salvageable area left. Then they go in, and this is what they do. They take out the thrombus through microcatheters. So this is a very upcoming field and very widely discussed in the social media as well as in the clinician fraternity. So again, another case of stroke. So you see this is the area of diffusion restriction here. So this is the brain which is already dead. We did a perfusion MRI. This is the normal brain which is perfusing normally, and you see this is the dead brain where there is no color. So what do you see here? Why is it different from the other case we saw initially? Yes, so you people are saying, nobody is saying it loud enough. Yes, so why do you think there will be no benefit? Yes, so very good. So there is no penumbra here. So this is known as a diffusion-perfusion match. And if the patient presents to you in this state, you have to go in for the normal non-intervention management of stroke and treat it like any other stroke. And thrombectomy will not help this patient. So this is the importance of having a MRI sequence done. So it is going to classify your stroke as in what duration of stroke your patient had. It is going to identify the area at risk, and it is also going to help you decide the further plan of management. So we'll just see a few quick cases of pediatric stroke. So this was a case we saw of a lupus anticoagulant patient. So do you see this was the first CT which was done initially in the emergency. This is the dark area, loss of gray white matter differentiation, effacement of cortical sulci. MRI was done. This is the diffusion weighted white on DWI, dark on ADC. So this is a case of acute stroke. And what is the territory? Again, it has been discussed. It was the middle cerebral artery territory, more distally so. So a focal block was found at this level in the middle cerebral artery. So this is the normal middle cerebral artery on this side. And you see how attenuated these branches are. So these were the clots. This was a case of focal arteriopathy. Again, there was a smaller stroke here, and the angiography performed revealed a block here at the level of proximal MCA. This was treated by intervention radiology. So this block was cured by placing a stent across the narrowed segment. So this is how strokes are being dealt now in the field of intervention radiology. This is again, the discussion of pediatric stroke is incomplete without mentioning this entity. So any of you have seen it in your recent practices, the residents? Have you come across? So yes, Moya disease is something which is not that uncommon, especially if you are practicing in a tertiary care center. So what is this? This is inflammatory disease or idiopathic inflammation of the intracranial arteries. And what happens classically is the supraclinoid segment of bilateral internal carotid arteries is obliterated. The brain then usually derives its blood supply from collaterals. You see, the rest of the arteries have not ossified, and it's all collaterals here. And this appearance on angiogram, this is a MR angiogram, and this is a real-time angiogram. And what is this appearance known as? So very good, so you have been reading your radiology well. This is known as a puff of smoke appearance. It used to be a very favorite MCQ question when we were preparing for our PG. So while my brief association when I was working with Bagur Institute of Neurosciences, we did this paper which was published in an indexed PubMed journal. We had studied the clinical spectrum in Moya disease in 8 pediatric patients. So you can just go back, it's free access. I'll just read this, I'll not get into the details. This was one of another cases from the series. Again, the classical puff of smoke appearance in a moya moya. Now we'll come on to the hemorrhagic stroke. So what is the major causes of hemorrhagic stroke? It can be an AV malformation, a cavernous malformation, an aneurysm that has ruptured. So importance for CT is, again, we have discussed. You can detect blood very well on CT, so you know this is a hemorrhagic stroke. But picture doesn't end here. You need to find out why this child had a hemorrhagic stroke, right? So that will be done by an MR, because we discussed MRI is better in picking up the underlying pathology. And like we saw in stroke, it can give us a time duration of what the duration of stroke is. In hemorrhagic stroke, the MRI can tell us how old is the blood which is accumulated in the brain. So MR is a very fancy thing. Neuroradiologists specifically love MRI. Again, I'll not get into the detail, but this is exactly how the blood changes its appearance on MR depending on the age of onset. And we will just see a few quick cases of hemorrhagic stroke. So this was a case of a cerebral arteriovenous malformation in the brain. The child had presented with hemorrhagic stroke. So AV malformation, this is a pictorial representation. There are abnormal communications between the artery and the vein in the brain. And obviously these are friable, they break and they bleed into the brain. Again, intervention radiology plays an important role. The intervention radiologist can go in and plug these communications and cut off the communication between the abnormal communication between the artery and vein and prevent this child from landing in the emergency in a bleed or having recurrent hemorrhagic strokes. Another common cause of hemorrhagic stroke is venous sinus infarcts. So arterial infarcts are mostly ischemic, whereas venous infarcts are mostly hemorrhagic. Very commonly seen in cases of pediatric population, in cases of SLE, procoagulant states. So this is exactly how hemorrhage will look like, and contrast enhanced scans will tell us that there is a thrombus in the adjacent sigmoid sinus here. You see the sigmoid sinus here is not opacified, so this was a case of sigmoid sinus thrombosis. And this is another fancy technique that we follow, which is an MR venography. So you see the right transverse sinus is fine, the left transverse sinus, the sigmoid sinus and the internal jugular vein has not opacified, so this was thrombosed. In a case of sickle cell anemia, again, see I wish life was that easy, but again, everything you see in the emergency that looks like stroke may not be a stroke. So what are the stroke mimics? You have to be very aware of these entities also. So there's something known as the posterior reversible leukoencephalopathy, epilepsy, all very broad topics in itself, not getting into the details. Infections, focal lesions like tumors, granulomas may also present like strokes, complicated migraine syndrome, and yes, drug toxicity. You cannot rule this out in an emergency setup. Just quickly have a look at this. So we discussed posterior reversible encephalopathy. So why is this reversible here? So we see this hyperintensity here. This is the diffusion sequence where this area is bright. Now just see what we just learned. This is the ADC map. Is this dark here? No. So this is not stroke. So important here is do not just see your diffusion weighted sequences. Always ask for those extra plates which are hiding in the bag of your patients. बाकी plates निकालिए, सारे plates देखने हैं, ठीक है? So don't make a diagnosis of stroke on a single plate. So this is white on DWI, also white on ADC. So this is facilitated diffusion, not stroke. This is reversible. The child will completely recover. So with this, we come to the end of our talk. So do you have any queries?
Thank you, Dr. Sudhishna Malakar, for your wonderful deliberation on this topic. Now we'll have a small inaugural session. We are having principal cervicals, deputy cervicals, and all the important faculties. I'd like to call Dr. Tishita Boshak on the dais. Please come. So I request principal sir to come on the dais. Yes, sir.
স্যার গাড়ো এদিকে এদিকে
So,
এদিকে সরো।
Principal sir, Professor Dr. Dilip Pal.
আরে তুমি বারবার
I would like to thank sir for helping every way to organize this workshop. Then I like to call MSDP sir,
দাদা একটু পিছিয়ে এসো
Dr. Sandip
হাত
Shaman
চলে
sir.
আসছে
Next, Professor Dr. Shapon Rai, sir, who is our President-elect IIP, West Bengal IIP. Dr. Sudeshna Malakar, our faculty. Dr. Mosum, who is our next faculty. And now we have our lamp lighting station. So I like to call all the faculties and the principals and NCs, so please come on the dais. We'll just light the lamp. সবাই আসুন। So please take a photograph of all of us.
স্যার একটু এদিকে স্যার এদিকে সবাই একটু ঠিক আছে
Thank you all. So just few words. So just
So I welcome the faculties of today's workshop as well as delegates as well as the President-elect the West Bengal Pediatrics as well as all the students and other I hope you will enjoy this neuroanatomy related neuroimaging. So always we the clinician we always try to elicit the clinical signs symptoms and again we have to judge with the help of the additional neuroimaging definitely. Neuroimaging has a definite role in the diagnosis and management of all the neurology pediatric cases. Thank you.
Thank you, sir, for your kind words. Now, our next speaker is Professor Dr. Shapon Rai. He will speak on introduction of brain tumor. I'd like to request sir to please come on the dais.
Good morning, everybody. So my job has been eased by my two previous speakers, Dr. Sophrobos and Dr. Maha. So I will just speak many of the slides which are common in the earlier presentation. First disclaimer, I am neither a radiologist and nor a neurologist. I am a pediatrician by profession and I have got a love for the radiology and that's why I am speaking my experience with radiology. So far I have gathered in Institute of Child Health and actually Professor Dipankar Das is my guru. He hasn't reached yet. Anyway, I would be happy if you could speak in front of Dr. Dipankar Das. This is the topic of today, MRI training children. So these two persons are famous. Can you tell the name of this two person? Can you tell this? No. Anyway, I'll come later with the history how MRI was invented. So MRI, actually all of you know, it is the scan utilizing a strong magnetic field and the radio waves to produce the detailed image inside the body, and it is actually a large, long board that contains a powerful magnet, and to cool the magnet we have to put some helium. So helium encircling the magnet, and MRI further is the best applications of the superconductivity in this area of physics, which directly help millions of people across the world. So this is what I was talking about. This is the helium, and this is the magnet, and there is the inner command, and this is the board where the patient cable lies. This is the cut section. You can see. So I was listening that my previous speaker was telling that CT is better sometimes because it incurs a less amount of time, in fact a fraction of a seconds nowadays. But MRI is not lagging behind. So there are few sequences and protocols that can pick up even the lung MRI in 25 seconds if I am not wrong. So they can pick up. But then they accuse, and now the people will do MRI more and more. And for the ionizing radiation, I have read an article that a single X-ray may be carcinogenic in later life. So we must think before we prescribe the MRI brain, particularly in unit. In our time, we used to see whenever there is any birth asphyxia, go for the MRI, CT brain. So at least you please don't do this. Sometimes it is required because if it is the child is very irritable or a movement disorder, then the child may be subjected to CT. So and MRI by the new protocol you can finish within 2 minutes. Within 2 minutes, and you need to have a very good Tesla. So now MRI is available from 1.5 to 7 Tesla. 7 Tesla. Not available everywhere. So before we are now going to the era of MRI, but we must pay our regards to the person who has discovered this NMR phenomenon. He is Dr. Professor Isidar Ravi, who has invented it, and he got the prize in physics, Nobel Prize in Physics in 1944. So MRI and its science has given 3 Nobel in recent years. So this is another Nobel Prize by the Felix Bloch and the Edward Mills Paulson in 1952. They also got working on particularly on the physics that liquid and solid can be subjected to radio frequency and magnetic inductions, and that can emit some of the property that can be captured by the scanner. So again, this Damadian in 1971, he is the person, the Raymond Damadian. He invented the MRI machine, also not so sophisticated, but he did the full MRI of a human body. And this was Paul Luteber, and in 1971 he demonstrated the image frequency of a signal, and first human imaging was done by this person. This is the Raymond Damadian, and this is the, can you follow this is the machine. The huge machine that he did, and actually he did the first MRI of a human body in 1977. So these are the types of MRI machine. All of you are aware of the fact because it's a closed type of MRI. And now this is the thing that is a table, this is the magnet, this is the coil, the radio frequency coil, and the radiant coil. And now we have got some open type of MRI. So the claustrophobia that usually occurred previously, that can be added by this open type of MRI machine. And with it, there are some of the machines that can use the upright position. The particular person or the child may be put in the sitting positions or even in the standing position. So this is the invention going on rapidly, and you have heard about the Tesla. Just now, Professor Diripala told me there is a Tesla, how strength is a magnet, and we can say it is a 1.5 Tesla, 3 Tesla, something like that. And you must also know this person. Is the Serbian American engineer, there is a Nikola Tesla. By his name, that Tesla goes, it means 1 Tesla is equal to 1 waver of magnetic field per square meter of the area. And already I have told the MRI machine is available up to 7 Tesla. What is the working principle? Dr. Somshubra Bose has already told you that there is no radiation. They use some magnetic force. The water molecule or the protons that remains in every tissue of our body, they are in a haphazard way, and when the magnetic induction is given, they reorient themselves. And when they again go to their original positions, they give some energy, and that has been picked up by a scanner, and the scanner they process the image and get different type of image what you want to. And this is what we call the spin. What he was saying, the haphazard arrangement of the molecules, and now with the inductions of the magnetic field, they are just very organized. Again, when you take up this magnetic field by the radio frequency, so they again go back to their position. This is the spin that we know, and is the pictorial presentations of the particular. These molecules, they go on spinning, and there are several axes, not only X and Y, also the Z axis also. So what are the sequences of MRI? This is the magnetic field, then radio frequency pulse. Then we give some time to relax for the tissues. And the comparison of the CT and MRI, you must know the CT always they need some radiations, and it's the absorption of the X-ray. MRI, it is by the magnetic phenomenon. Radiation exposure is nil in MRI. Tissue resolution is good in CT, but excellent in MRI. And if the dynamic diagnostic information in CT is not so good, but it's very easy in MRI, and the CT is being influenced by the ear and the bone, but MRI it is not. And the brain, CT can give you only one thing. It's a transverse plane, but here in MRI we can do lot of planes. I will show you later. And examination time is short. It is 5 to 10 minutes, particularly in CT, but MRI it may go up to 30 minutes. But things are changing very fast. The preferred area, MRI is particularly important in brain and MRI. And it can be done also in lung. In our hospital, we are doing not CT of the chest, we are doing the MRI of the chest nowadays, and we are getting the satisfactory result because the spatial resolution is bit low, but ultimately the informations are same as CT. So this is the advantage of MRI. Already we have gone through this. No radiations, images are recorded in many planes. There is better soft tissue contrast. The MRI can be done even without dye. In CT you cannot imagine without dye you can do arteriogram. But here we can do. And often we don't use any contrast media. And the advances of the technique which has been shown by the previous speakers, there is a MRI by the diffusion, the ADC, the spectroscopy, the perfusion, and the SWI images that are also helpful to delineate any anatomical defect or any functional defect. And MRI has got a functional MRI that can detect what is the oxygen content of the blood in the particular area if that particular brain region is activated by any of the functions they are doing. So we can now detect here the frontal lobe is doing their work. So if you go for a functional MRI, you see the oxygen content of that particular area may be higher than the other area. So this is another advantage of the functional MRI. And it can pick up, the people used to say you cannot take a nodule less than 3 millimeter. Yes, it is less than 3 millimeter MRI, it is very difficult. But 3 millimeters and above, the MRI can pick up. And we are lucky that most of the time, the nodule size is more than 0.3 mm. And it provides high resolution of the posterior fossa. So if you want to see the posterior fossa, like the press, so you have to go for an MRI. And if you want to see the base of the skull or the orbit, MRI is better than CT. So if you want to see a MOGA, if you want to see a MOGA, you should just go for an MRI of the orbit. So you can pick it up very well whether there is some edema or some type of narrowing of the optic nerve or not. So can you tell me who is the player? Yamal. So MRI is just playing like Yamal over the sea. And what are the disadvantages? There are some disadvantages of the MRI also. It is more expensive. CT is not so expensive as MRI. It takes longer time of acquisition, I admit. But the high noise sometimes disturb the children. So if you just give the peripheral, so you will not be feeling asleep, and sometimes there may be problem. And again, you have to get a mirror or something like that. That is not possible always. And more claustrophobic because that CT, because it has got a long board, but it can be added by using an open type of MRI. And the MRI is subjected to various unique artifacts that the interpreter must know. The radiologist, we pediatrician, we are lucky that will be held by the radiologist. And the MRI is not safe for the patients with a metal implant on the foreign body. Say I have got a plate over here, so I cannot go for an MRI. So because that is a maybe magnetic. Nowadays, all the implants are MRI friendly. They are not ferromagnetic. So another problem is that the slice section. In CT, the slice is very thin, 1 millimeter. But in case of MRI, in particularly in 3 Tesla machine, it is 3 to 5 millimeter. But in 1.5, it will be 3 to 5. But in 3 Tesla, it will be 2 to 3. So it's a marginal improvement. But CT, they got very thick, so they cannot miss, and that's why less than 3 millimeters of any nodular saddles can be picked up well by the CT. So you can miss sometimes the nodular saddles. So ideal to be avoided. All ferromagnetic substances to be avoided in MRI. So when you use the phone, you use the wristwatch and the credit card in your pocket, you have to keep this thing. And now the they are doing the dental wand. If you have got a replaceable dental wand, you have to keep it outside. So you have to take it off. And you must know that the pin, knives, eyeglasses, the body piercing now, in the tattooing and the body piercing, you have to avoid. Some of the things that you should display in front of the MRI machine, these are the in particular the aneurysmal fee or the PDA banding that we do to close the PDA. So any stimulator or the infusion pump, it should be placed over the MRI room, examination room. And some of the cochlear implant, not all, some of the cochlear implant should be seen whether it is compatible with MRI or there will be problem, the aneurysmal fit and some of the cardiac defibrillator. Now, if a child is very moribund, So you are taking an unconscious child with some of the convulsions, so that may cause some problem, and you have to sedate the baby. So you have to use some long circuit which is comfortable in the MRI without any ferromagnetic substance. We call it the vein circuit or the bifurcated long circuit that has been taken from the anesthesia department. We do in our center also. And very agitated patients or the convulsing patients, or if the patient has got a uncontrolled movement disorder, so there are relative contraindications. And usually obese patient may have some problem because it is not only the bone may not fit the tummy of the patient. So nowadays with the jumps, the boys are getting more and more obese, so they fit some problems. So these are relative contraindications. And the claustrophobic patients, so they cannot move. And that I was telling, some of the ventilator even are MRI friendly, but infusion pump no. So you can take this bleeding circuit, the long limb, dual limb, and it is called the vein circuit. So sometimes it has been used in our hospital. So what I was telling about the functions in MRI. So what is the difference of the functional MRI? You can see this is the normal one, this is the functional one. It actually detects the oxygen content of the blood vessel supply in that particular region. Image spectroscopy is another added feather on the cap of MRI. So you can get an image spectroscopy, particularly the environment of the brain, how the molecules behave. So we can see the pulling surge or the NNS and the creatinine, and by seeing the ratio we can say what type of lesion that may be. This is another thing that I am very much fascinated with this diffusion tension imaging. You can see a lot of colors. So now we are not staying in the world of black and white or saturated gray. So satranj khiladi bhi to hai na, color. So in MRI is also some color involved by the DPI, and believe me, the attention deficit disorder or autistic disorder can be picked up by this DPI. And there's a beautiful article, a comparable structure brain imaging finding in autism spectrum disorder and ADHD. So I was fascinated by this article, and that's why I went on reading about the DPI. But in our setup, when I told you have to use that, they said, particularly that protocol should be purchased by just 30 lakhs rupees. So naturally the admin, like, believe that they didn't allow. So there are, this thing already has been taken by Dr. Malakhan. So hyper-intense means we call it as a not iso-lens or radio lens, just like that, or the radiolucence. In the language of MRI, the images is described by the intensity. So bright, we will call it the hyper-intense, and if it is the dark, we will call it the hypo-intense. And with this knowledge, let us go for the planes of the MRI, because if you don't know the planes of the MRI, it is very difficult. So this is the axial plane, it means you cut up like this, and the coronal plane you cut like that, and sagittal plane it is the lateral like that. So this is the axial, this is the coronal, and this is the sagittal. This is the axial, this is the right, and this is the left. Not this is the right, this is the left. Just like the chest X-ray or an X-ray, the right upper person would be the left of the patient. This is the superior, this is the inferior, right and left. This is the sagittal. We saw the beautiful picture presentation by Dr. Somshu proposed earlier. So this is the corpus callosum, this is the lateral ventricle, this is the sulci and the jugular. So now anatomy particular, I think, do you need to recapitulate the anatomy, or otherwise I will skip it? So this is the skull. Skull in MRI will look hypo-intense. So it is not bright, but the fat, the skull contains some fat tissue, it will look like white. So this white is not your bone, just like the CT. So this is the skull, and this hypodense area, the black area, that is the skull. And you can see this is the falx cerebri. I'm going very fast. This is the brain stem, this is the cerebellum, this is the tentorium cerebelli. This is the right hemisphere, this is the left hemisphere, this is the falx cerebri, this is the cerebellum. This is the cerebral hemisphere, corpus callosum, this is the brain stem, this is the cerebellum. And now you must know the CSF phases, the gyri and subset, because there are some implications when I will tell you the Ullage area, what is Ullage area is, so you must know it. So just think about the mountain and the valley. If you think that the mountains, these are the gyri, and the valleys are subside. So it will be separated by at least one or two subside. So deep one is subside, the mountain, the big one are the gyri. And now this is the axial brain. You can see the lateral ventricle, the blue one, the foramen of Monroe. This is the third ventricle. This is the posterior part of the lateral ventricle. The posterior horn, it is dilated, we call it posterior forceps body. And this is the another picture just like the near the fourth ventricle. This is the brain stem, this is the basal system. You can see the eye and this is the optic nerve over here. Now this is the area in sagittal section. You must know which are the ventricles and which ventricles are there. Because in ICH, when I was there, so there were a lot of confusion about what are the ventricles, third, fourth, something like that. So this is for your presentation, this is the lateral ventricle, this is the third ventricle, this is the aqueduct of the sylvius, and this is the fourth ventricle. And what Dr. Shomshukra has already shown is the optic chiasma, the pituitary stalk, and the pituitary gland. So I think you will be able to diagnose all this structure now because there is a repetitions. So I am skipping that. This is the gray matter, this is the quadrate lobe in front. So this is the green one, quadrate lobe, this is the lentiform nucleus, and these are the two other thalamus, red one other thalamus. So if you see, this is the quadrate, this is the lentiform nucleus, so medially it will be globus pallidus, laterally it will be the putamen, this is the hypotenuse area you are seeing, this is the internal capsule, and these two are the thalamus. So white matter, most important structure is the corpus callosum because it is the connection between the left and the right hemisphere, and a lot of information goes from left to the right and right from the left. And you can see this is the genu, this is the splenium, and over it is the body. Okay, so I will show you one picture where you see the hypoplastic corpus callosum. Not agenesis of the corpus callosum. These have been taught very clearly by all these two speakers. This is the anterior cerebral artery, medial cerebral artery, the posterior cerebral artery, is the internal carotid, and this is the particular arteries. I am not going in details. Veins also are taken by Dr. Shomshukra Bose. This is the superior sagittal sinus, this is the inferior sagittal sinus, this is the transverse, and this is the sigmoid sinus. So now I will go direct to the MRI. So MRI sequence, we usually use T1, T2 and the flare. So in T1, just keep in mind, the CSF will be black. CSF will be black. So and the gray matters appear gray and the white matters appear white. So T1, CSF black, white matter white, gray matter gray. The basic investigations that we do, and T2, just the opposite. So the CSF will be hyper intense or white, or the thalamus will be darker than the corpus stratum. You should not remember this, but the white matter will be lucent or darker, and the gray matter will be also gray. So these are the MRI sequences already talked. This is the T1, T2, the flare, what is the star, the beta provide, the ADC, and the diffusion tension imaging. I have already shown you the perfusion weighted imaging. I will just touch those. And the susceptibility weighted imaging, we can go for MRI angiography, MRI venography, and more on the top of it is the MR spectroscopy. It's very good. And MR perfusion, and you can see also the functional MRI, and I'll show you a picture of the tractography. So this is the T1, you can see the CSF is black, and this is the white matter, it is white, and gray is really looking like gray. And here, just keep in mind, I just remember like that. So it's a very short T1, T2, so it cannot reach to the CSF. But if once it reaches the CSF in T2, the longer time, the CSF will look like white, and the gray matter will look gray, and you can see the white matter is just like a hypo-intense. So it will look like a black one. This, if you just remember this one, T1 and T2, by seeing the CSF, you can easily diagnose which modality you are using. So this is an intense case, it is not very required for you. Now this is a Chiari malformation, later tell you this thing. And this is a fluid is bright. Any fluid, not only CSF, any fluid will be bright in T2, the white matter is darker than the gray matter. So this is the T2, what is this? CSF is white, gray matter, gray, and this is the white matter, this is the darker than thing. So this is the axial T2, this is the corona. So CSF is again white, and this is the gray matter, and white matter again looking hypo-intense. Flare, fluid attenuated inversion recovery, commonly used sequence similar to T2, but already told you the fluid is darker or suppressed. We have to suppress that particular CSF fluid or any fluid. It is useful when you will require. If you want to see any edema or any information, so you just tell the radiologist that I want to see whether there is any brain edema or not. They will go for a flare study, and they will give impressions that what they saw, and usually identify plaques of the multiple sclerosis. We are lucky in pediatric population, multiple sclerosis is not so evident, but thing is that we are getting cases of multiple sclerosis nowadays. We are getting. So clinical applications, this you have to remember. Infarction, the multiple sclerosis, subarachnoid hemorrhage, trauma, post-contrast flare is seen and assessing the leptomeningeal diseases, particularly the meningitis. If you want to see the effacement, it's better to go for the flare. So this is the T1, T2 images, both of us are taken from the same source. So this is the T1, this is the T2, and this is the flare. Now you can see it is the same, but the CSF has become black. This is the metastatic melanoma. You can see lot of edema is seen, and now if you go gradually, this is the pre-treatment, this is after treatment, and this is after 3 months. So you can prognosticate the treatment or the effect of the treatment by the MRI without giving any radiations injury to the particular child. So DWI, you must have a clear concept of the DWI, what Dr. Malaka has already discussed. There is a Brownian motions of the water molecule, and in water molecule remains the hydrogen ion, and that is the proton. And proton clip that we can see by the DWI images, and it looks like a black image. And DWI picked up very small and early in fact. So what is the implications of DWI? It can pick up very small and early pick up that we cannot pick up by the T2 or even the CT. So conventional MRI T1, T2 may not detect infarct as early as 6 hours. But you want to see the infarct, but you don't want the CT, go for the DWI. And the CT fails to detect a very small infarct. Restricted diffusions occurs in strokes that we have already seen in abscesses and tumor. So, what are the sequence of events in infarct? There is a DWI in minutes we can pick up. And ADC, there will be initially reductions. So, there will be subsequent increase in the ADC value, and there is a pseudo-normalization. Ultimately, there will be permanent increase. So, just keep it in mind, in DW-weighted image, CSF will be black. And the white matter, hypo-intense, gray matter signals just like the gray. Just opposite is the ADC. So apparent diffusion coefficient, that is the ADC value, it just look this thing. This gray matter is gray, white matter hyperintense compared to the gray matter, and CSF will be looking white. That's the opposite of the DWI. So this is the thing that we have already seen. This is the DWI weighted image, and this is the true restricted image. Now it is looking, the CSF is white, and this is the hypointense on the target. So this is the diffusion weighted image in case of any ischemic stroke, and this is how DWI can pick up gradually, particularly the changes that occurs over months. This is the use of it. So this is the DWI and the ADC value. So this is the DW and this is the ADC. You can pick up any conditions over there. So this is the MCS stroke, already has been discussed. So I'm skipping this slide. And this is a stroke. You just see there is a just opposite of it. So general rule in MRI, all infarct, all SOA, all intermediate changes, the hypointense in T1, but hyperintense or white in T2, hypointense in flare, except fat is hyperintense in T1. Just keep it in mind, because in the first we have seen the outer layer is not the scar, it is the skin. Gradient echo GRE. GRE is a T2 based sequence, very sensitive to detect micro MRI. If you want to see less than 5 millimeter, so you just ask the radiologist, so you have to see any micro hemorrhage or not, so you have to gradient echo. So GRE, the implications of doing GRE is for detections of the micro hemorrhage. This is the thing that we can see. This is the CT scan. You can see the scar looks white, but here the scar is radiolucent. So the T1 weighted image, the T2, and the gradient, you can see the area particularly, it will be periphery of the image is iso-intense, consistence with the deoxidation that occurs more evidently in the border. So in the centers of this particular image, you can see the hyperintense, but the periphery, you will see the hypointense, because these are the particular area of the vulnerability. So this is the STAR, it means the short-term inversion recovery. So STAR is the inversion recovery pulse sequence. The specific time has to suppress the signal from the fat. So if you want to suppress the fat, you have to go for a STAR sequence. And all the easiest ways of the STAR is to look for the fat and the fluid spaces in the body. So fluid is always be very bright, and fat will look very dark in STAR sequence. My guru has already come at the Vibhav. So pathological process normally increase the water content. If there is any pathological process, say SOL or any hemorrhage or something like that, that will contain more water molecule, and due to the added water molecule, the result in the signal increase in the STAR image. So STAR image looks, because a lot of water, lot of protein, so it will look brighter. And STAR sequence is used to detect any neoplastic or inflammatory tissue. So diffusion tension MR imaging is a fascinating one. So it is the extension of the diffusion weighted imaging, and it allows, based on the data of the white matter tract orientation. We will see the white matter tract, and the fiber tractography is a 3D reconstruction technique that assesses the neural tract using data collected by the T1. So this is the DTA, and you can see the tractography full of colors. So what things we should see, whether it's the red or the green or the blue. Blue goes from upper to lower, superior to inferior, and the anterior posteriors are blue, and green and the red are from the left to right. So what is the clinical applications of the DTI? It means diffusion tension imaging. If you want to see the deformation of the white matter by any tumor, the deviations or the infiltration or the destruction of the white matter, you can go for the DTI. brain, or pre-surgical planning or getting the anatomy of the immature brain. The Alzheimer's disease, and already I have told in our particular we are interested in detecting the ADHD and the autism spectrum disorder. And the perfusion weighted imaging, what Dr. Malapur was telling, is the thing, the perfusion weighted MR imaging in the term used to denote variety of the MRI technique able to insert the perfusions of the tissue by blood. So what they use a different technique detecting perfusion parameter, and the most common techniques that use are the ASL and the DSC. So you should not bother about that. For the clinical applications of the PWI, perfusion weighted imaging. So what they do, the role of perfusion images is that acute cerebral infarct that determine the ischemic penumbra. So the penumbra you have already noticed what she has shown, and in more disease to identify the vascular disorder, and also to see any degenerative, neurodegenerative disorders or not. And these are the diffusion weighted imaging pre-treatment, and this is the post-treatment. You can see the penumbra over here. You can penumbra, and penumbra is green particularly in this area. Okay, and the infarct is red. Infarct is red, and this one is the penumbra, and incorporate the concept of the auto-regulations. So I'm skipping the functional MRI, as I've already told you that it detects some of the oxygen contents of the particular area, and if any neuronal activity is there in a particular region, so what will happen, you can see increased oxygen supply to the by the particular artery, and during the capillary and the vein, there will be more oxygen in the vein end. So you can pick up that. I'm giving you the example. And the functional MRI, in most of the cases, superseded the PET as a tool to study the blood flow and the oxidation changes. So we thought PET scan is better, but in MRI, you can jolly well do by the functional MRI, you have got a particular facility. So this is the functional MRI speech. You can see the area of the activity, the listening, and the finger tap. So with this background knowledge, let us now move to very quick cases that will be required for your day-to-day practice and your DNB and MD exams. So ready? Okay. What is this? What is this? This is very obvious. This is hydrocephalus. Excellent. So this is the lateral ventricles are wide enough. So I have already shown it. You just see the salsa and the gyra over the normal brain. And here it is very small. So this is lysencephaly. So if the gyra and salsa are very small, it is lysencephaly. What is this? Schizencephaly. What type of schizencephaly? Openly. Sir, you are in a position of a faculty. let the PGDs answer it. Okay. So this is the open. You can see the gap between these, and it connects between the lateral or the subarachnoid space. So this is perfect. And closed lip, it will be closed. This is my case of open lip schizencephaly in MGM Medical College. You can see these the connections between the subarachnoid space and the lateral ventricle. This is a beta view. And this is, we have already shown the adults. There is also a cleft, but it is apples. So this is a closed lip schizencephaly. Excellent. What is this? Not colpocephaly. Colpocephaly is the dilatation. There is something else over here. The podencephaly. So it should be surrounded by a white matter, and it can connect from the lateral ventricle to the subarachnoid space. So this is the podencephalic cyst. What is this? Very good. Holoprosencephaly. So this is a inappropriate separations of the both lobes. So there are several times alobar, semilobar, and the lobar. If you just can say in the examination is the holoprosencephaly, you will get the marks. The white matter disease, you must know what is the white matter disease. I'll just tell you a few points that you can diagnose. The serious affection is there. The white matter disease is maybe the Canavan, Alexander, religious Mountbatten or adrenoleukodystrophy. If there is serious with peripheral nerve involvement, it may be metachromatic leukodystrophy, maybe Krebs, it may be the Cochran syndrome. But just seeing the posture, the clinics, if you see the office tonus, it is the Krebs. With the hypotonia, it is metachromatic leukodystrophy, and it is the fibroderma, or as we call it the Cochran syndrome with xeroderma pigmentosa. So XP, so it is the Cochran syndrome. So what is this diagnosis with this? Excellent. This is Alexander. তোমাদের আর বইয়ে কোনো লাভ আছে নাকি? মনে হয় না। Alexander disease. Very good. Frontal lobe is involved. So this atrophy of the medulla and the cervical. Why I have given this? This atrophy of the medulla and the cervical cord, we call the chipmunk sign. So those with the appearing examination, Professor Dipankar Das, he will ask you this question with the chipmunk sign. So this is yes, excellent. This is the Canavan disease, and you can see the tigroid appearance. So now people are saying that the butterfly lesions or the tigroid lesions. So this is the leukodystrophy clinically manifested by the Alexander Canavan. And there is severe mental neurological deficit, and they may have blindness also. And what I was telling, MR spectro, what I have given, MR spectro is very important in particularly in Canavan disease. What you get is the elevated NNA level and the NNA creatinine level. So just remember the mnemonics, SCANA and NAA. So NNA will be elevated. What is this? I think you will be able to answer. Yes, somebody? Adrenoleukodystrophy. Excellent. So this is the fever, gait disturbance, visual loss. So this is adrenoleukodystrophy. The MRI brain shows the confluent and symmetrical bilateral hyperintensive, particularly the parietal occipital region, the apostolic radiations, and the cerebral parental alveoli. So what is this? I am dealing with the white matter disease. So this is metachromatic leukodystrophy again. So this is the metachromatic leukodystrophy, and you can see the smearing of that particular area. This is the periatrial area. So this triangular area, this will be smeared. So this is metachromatic leukodystrophy. So we call it for the tigroid pattern, but sometimes the people say it's the butterfly pattern. Am I right, Baba? So serum and the urine aryl sulfatase level will be reduced. So if you want to get a marker to confirm the diagnosis, get a serum or urine aryl sulfatase level and it will be reduced. So what is this? It looks like metachromatic leukodystrophy, but this is religious Mountbatten disease. So usually the males usually suffer more because it is an X-linked disorder. The presentations of the pendular eye movement, the nystagmus, hypotonia, ataxia, pyramidal disease. So it is the pendular nystagmus always seen in a child with ataxia. Think about the religious Mountbatten. What is this? Can you see the other band over there? This is the band heterotopia. It means the migrations occur from the side of the lateral ventricles, and the more younger ones that traverse the early form neurons, and they traverse. If there is any arrest in the migration, that is formed, it is called the double layered cerebral cortex. So the band heterotopia. And almost only in women, they usually happen, and this is called double cortex syndrome also. This is, I'm coming to the end of my session. This is the, can you see the the candle-tip appearance. So this is the subependymal tumor. So this is the case of tuberous sclerosis. So the cortical or subependymal tumors are there, and the white matter abnormality very associated with the tuberous sclerosis. What is the, people will ask, what is the word tract? This is the walk, this is the word tract. So this is the seizure, intellectual ability, disability, and evasion. But mind that only 1/3 of the patients of tuberous sclerosis you can get that word tract. So tuberous sclerosis is a phakomatosis or bone village disease. So this is my case in Indian medical college. If you just compare these two, you can see some problem is there in the right cerebral hemisphere. What is can be the diagnosis? Yes? Rasmussen encephalitis. So this is the case of Rasmussen encephalitis. Excellent. So what is this? Again, similar type. The atrophy, slightly hemi-atrophy of the brain, and you can see is the acute leukoencephalopathy with restricted diffusion. So we call it the alert syndrome. Alert syndrome, because I got this case, that's why I'm showing it. So we can get this sign, we will look at the bright T sign. So bright T appearance over the frontal region, this is the alert syndrome. And these are the things that you can get in the birth asphyxia, particularly hypoxic ischemic encephalopathy. There is a common place is the basal ganglia hyperintense signals, particularly in case of the decoupulated images. And there you can see the slippage or bilateral symmetrical gliosis over there. And you can see also the ulegidia. In ulegidia, the gyrus will look like a mushroom appearance. So we call it the mushroom-shaped morphology of the gyri is characteristics of the ulegidia is seen in case of birth asphyxia. And this is the subcortical type of hyperintensities over there. It's very rare, but sometimes we get. And this is the graded one. This is the thing that is the multicystic encephalopathy, 5-week-old. And we have got our own case over there, much worse than what we saw is the due to the birth asphyxia that we see in our hospital. So the brain injury, I'm skipping that, there is a lecture of that, and this is the, what is this? Cystic sarcoidosis with the divisional edema. You can see the scolex also. And this is the, we have presented with Dr. Preeti Kenka the starry sky appearance. This is naturally, if it is the cystic sarcoidosis, it will be tuberculoma. This is tuberculoma evident. And this is the ragged appearance of the edema. So this is the difference that I asked during my questions. There is a difference between, I will take a snap of it. So difference between tuberculoma and NCC, size will be more in tuberculoma, more than 20, size will be less. These are lobulated or irregular in tuberculosis and marked edema with the midline seam. Never offers midline seam in case of NCC. And there is a round or so what is this? Cheerleader. Yes, cheerleader malformation. How do you take the thing? The Bayesian. Or this is my case. This is my case. So you take a region from the Bayesian to the Opisthian and you see how much is the displacement or the herniation of the cerebral tonsil. So if it is more than 3 to 5, in adult it is always 5, but in children we can get up to 3. If it is more than 3 to 5, it is suggestive of the endometrial herniation, so it is a cheery malformation. So this is my case, there is a meningocyst, just got a month back, and this is the thing you can see. What I learned from Dr. Dipankar Das is that the hydromelia or the syringes, and we can see, and this is, can you see the picture? There is a fragmented, or the sometimes there is a lytic lesions over there, and the GI2 malformation. So this is the diagnosis made by our institute, and this is the Bayesian and Augustian, how you take the advantage. You can take also snap of this. So this is why I say the corpus callosum, not agenesis, the hypoplastic corpus callosum. The most of the part of the corpus callosum is absent. So near total corpus callosum agenesis. This is the case that I got a month back. The child has a very microcephaly, weak, the child cannot walk, delayed milestone. So I went for this MRI, and MRI you can see what is this. The Citibian features are very prominent. So this is a uric aciduria type 1. What is this? This is my case that I have published the data on this ADEM, particularly with the COVID MISC, and this is the thing you can see the hyperintense signals over the right side of the cerebral hemisphere. So this is not uncommon that the ADEM is not seen in case of the MISC in children. So this is our case of the ADEM. This is the only one case that I got there. What is it? The child, large skull, the child cannot walk, stand. So this is the positions of the lateral ventricle, and the third ventricle, also the fourth ventricle. So this is the beta view you can see, and the hypoplasia of the cerebellum. So the diagnosis is what? Follow? Dandy-Walker malformation. So this is the Dandy-Walker malformation. So these three things: agenesis or hypoplasia of the cerebral cortex, the aggradations of the fourth ventricle, enlargement of the posterior fossa. So I think I will conclude my session with a thanks. I think no butterfly of the metachromatic leukodystrophy, but let your life be full of the flower and the butterflies. Thank you very much.
Thank you, sir. Thank you, Professor Raj. Excellent deliberation MRI. It was such a lucid and very much informative. So if the students, if you have any questions, they can ask. By the time we are ready for the next speaker, Professor Dipankar. Our next speaker is Professor Dipankar Das, who will speak on MRI in epilepsy, a structural pathology.
Okay, good afternoon. Thank you, Gary Babu. You have made my life easy. You have told everything about Emma. So I will go briefly and save everyone's time. And because the topic is on structural pathologies, so we will restrict ourselves in the anatomical part of this epilepsy. But beyond that, there are functional things what Professor Rai has told just now. functional imaging and MR spectroscopy. So first we need to know, I know you know all the difficult things, but I surprise when it comes to the basic things, there is definite lack on the part of the examinees. So if you can't answer the basic questions, they will not ask you the tougher questions and give you the worse marks. First you have to pass. So that's why I will go through the basics and let's see how it goes. So first thing is embryology. I will briefly say, you know that the neural tube forms the spinal cord and rostral part of the neural tube. There are primary brain vesicles which later on forms the brain. And along the lining of the ventricles there are the germinal matrix, where from the cells the neurons are produced and they migrate peripherally. So in this process the glial cells take major role. They provide nutrition and guide the neurons to go. So there are three stages. One is proliferation, then neuronal migration, and then finally cortical organization. And after that there is myelination. So any of the process can be hampered, but for epilepsy the cortical things are more important because they are more often epileptogenic. But any scar, any astrogliosis in the brain can produce an epileptogenic focus. So etiology of this malformation of brain are not always known. As you can see, it is unknown in 60% of cases. This is, I suppose, a old data. Nowadays they bring out any genetic explanation for everything. Even your son doesn't look after you, there must be a genetic basis. So some gene is responsible. You don't know what is that gene. So all this come up. But certain factors are there like maternal diabetes, teratogens, drugs, and infection, which is preventable. These viral infections and Zika virus will come along with all these viruses mentioned here. Torch is the most popular and well-known entity. Cytomegalovirus is one of them, which produces these cortical malformations. And some viruses are notorious for producing calcifications, you know. So this is neuronal migration, as I told you. The genes involved in this neuronal migration process are LIS1, filamin 1, DCX, renin and myrcene. And in bracket you can see the role of these genes. This is a age-old image from Barkovich, the schematic diagram, where you can see these are the ventricles, and along the wall of the ventricles are the germinal matrix, which is a high vascular zone, and that's why it is prone to hemorrhage. So from germinal zone, the neurons are formed and they go to the cortex with the help of the glial cells. The colorful picture showing the neuronal migration process. But this is a normal brain, I think. So can anybody say, is it really normal or any abnormality is there? So you have to know first how much is the cortical thickness. You have to see millions and millions of cortex before diagnosing a subtle cortical dysplasia. You have to train your eyes because you are seeing a lot of images in a very short time. You will not get whole day to go through a brain image. So that's why you have to know how much is the cortical thickness. So you can see these cortex are normal. Normally 1, 2, 3 millimeter max to max. This is a pencil line cortex. And this cortical white matter junction in this Q1-weighted images will be always very sharp. And if you see any blurring in any of the cortical white matter junction, then you have to verify that in the orthogonal plane. That means 90 degree of the plane you are seeing. If it is an axial image, you have to verify that in a coronal or sagittal plane. In at least two planes, you have to justify the blurring. Otherwise, just seeing in one plane, you can't say that this is a dysplastic or abnormal cortex. This is the first lesson. Suppose here you see some amount of blurring is there in this cortex. It is very difficult for non-pediatric MR radiologists to pick up this. This cortex was abnormal. This is an abnormal cortex. But firstly, we are seeing it in axial images. Fine, but I have to corroborate that in other images. And very thin, we have got ultra thin slices less than 1 millimeter, 0.5, 0.6 millimeter, reaching the level of microscope slowly. So, these things are very important to see the subtle cortical dysplasias, which are treatable lesions surgically. So, this is one. Number two, if you see what is the importance of this high resolution MR and high definition MR and high field strength beyond 1.5 Tesla. So that is the thing, where you see the gray white matter junction more and more beautifully. You see, if you compare with the cortex here and cortex there is some difference. What is the difference? Can anybody volunteer? There is difference. Yes or no? Say yes or no. Yes. So what are the differences? See, one thing is this cortex is thicker than the normal side. And see the cortical white matter junction. See, this is reasonably blurred. You can't see sharp margin like here. And see the outline. This is the normal cortical outer surface. This is the normal cortical outer surface. Just see here. Yeah. See this one. So outer surface is a little bit nodular or wavy or irregular, whatever you say. And this gray-white junction is blurred. So this is an abnormal cortex. First, try to identify normal and abnormal. This is another thing. This is from a very old, my first equipment, 0.2 Tesla. Why I have kept it? That magnetic field strength is definitely important, but you have to prepare your eyes also. See, here, this craniofacial disproportion, you don't have to measure with the tape. You can easily say that this is a microcephalic child. And see, this sulcation is reduced. Number of sulci are reduced. So, another example, here also the number of sulci are reduced. Are they same? They are not same. Why? Because see the cortical thickness. Unless and until the cortex is thickened, you can't declare that it is abnormal. That is one thing. See on the left side, there is also paucity of sulcation, reduced sulcation. But this is what? This is a premature sulcal pattern. In any normal child with prematurity, you will get less number of sulci. But see the cortical thickness here, and see the cortical thickness here. Your cortex starts from here and up to this. So this is the white matter, myelinated white matter, and this bone is the cortex. So if it is cortex, so it is reasonably thickened, and see, this cortex is not thickened. So this is a premature sulcal pattern, and this is an abnormal cortex. This is called pachygyria. In pachygyria, the surface is smooth, number of sulci are reduced. In polymicrogyria, the cortical thickening is there. Along with that, the outline is irregular. I am showing examples of that. These are epilepsy syndromes I am coming. See, this is what? There is reduced sulcation, You see, and the gray white matter is sharp. There is no blurring. So this is not dysplastic cortex. This was the old case of myself showing torch infection. In torch infection, what happens? There is usually cortical organization defect, along with some white matter signal changes. See, these are the white matter signal changes, periventricular regions, and at times in CT scan you can get calcification, on MR also, on GRE images or on SWI, you can see the calcifications, but along with that in MR you can see better regarding the cortical information. So if I go to the next, you can see this is our recent 3 Tesla and this is 1.5 Tesla. See the difference. This is the flare, same flare image. You can see the gray white matter much better, and this cortical thickening you can appreciate. You can see the white matter signal changes also. So on CT scan you can see the calcification. This is a classical polymicrogyria. Look at the cortex. Not only it is thickened, you can see the irregular and multiple small gyria are there as compared to this unaffected or normal area. So this area is abnormal, this area is abnormal, and in smaller children it is better to see on T2-weighted images. Why? Because the white matter is bright, unmyelinated. That's why you see the relatively darker gray matter better on T2-weighted images in small children. But in older children or in adults, these are better seen on T1-weighted images. So see, on T1-weighted images you can also appreciate, but it is better on T2-weighted images, this polymicrogyria. This is another patient with polymicrogyria. See the gyria. So try to remember the appearance. These are irregular, sawtooth-like. These are all polymicrogyria. This gyria not normal. This is what? Dr. Shapatra has already shown you this case. Sorry? No, not lysanthropy. Sorry? No. This is heterotopic gray matter. You see, this is gray matter intensity and it is closer to the midline in subcortical location. So these are all heterotopic gray matter, and along with that there are ventricular problems and corpus callosal dysgenesis, etc., etc. But primarily the thing is epileptogenic focus is heterotopic gray matter. So heterotopic gray matter can happen in subcortical location, in subependymal location, like a band. So this is subependymal. So when you look at the images, you see the ventricular margins because of 2-3 reasons. One is any subependymal lesion like germinal matrix hemorrhage, like calcification, like heterotopic gray matter, subcortical tumor, and in post-contrast study, not to miss ventriculitis. So this margin of the ventricles, you should make a habit to see the margin of the ventricles. See this appearance, these are all heterotopic gray matter. And on T1-weighted images you can appreciate better. This is the gray matter intensity, and if you compare with the cortical gray matter, see this is the cortical gray matter and this is the heterotopic gray matter, bearing the same signal intensity on all pulse sequences. Means Q1, T2, flare, every sequence will show the same intensity as the cortical gray matter. So another subcortical large heterotopic gray matter here. This is called transmantle. That means it is traversing through and through the hemisphere, from the cortex up to the ventricular margin. Another patient with right frontal, this is the heterotopic gray matter. This is what? This is from our older equipment. Say, This is the cortex, outer one. And after that you see a bright line. Something bright substance. What is this? That is white matter. Again you see gray matter. Again you see some black things. Those are myelinated white matter. This is unmyelinated white matter, also called cell sparse zone. So that means this is a band like gray matter intensity surrounding. So this is band heterotopia. At times it is difficult to diagnose. That's why I am showing this slide. This is very easy to diagnose, this band heterotopia. As shown by Professor Rai in the previous images, this type of band heterotopia you can easily recognize. But this is not easy because the band is very thick. It is reaching almost up to the cortical surface. But you must look at the subcortical white matter, which is unmyelinated, and this periventricular white matter, which is myelinated. Both are white matter. So it is written lysencephaly, smooth brain, and hourglass configuration. This is the extreme form of pachygyria, often called agidia, pachygyria complex, like that. So because in pachygyria also you get less number of gyri. And another thing is hemimegalencephaly. One side of the hemisphere is larger than the other, and this hemisphere contains what? This is a thickened cortex. And you see the irregular, ray white junction is irregular, and the cortical surface is also irregular. If you compare with the normal cortex here, this is very much definite that this is a thickened cortex with irregular outline. And this cerebral hemisphere is relatively larger, so it is hemimegalencephaly. Another patient with hemimegalencephaly, they will have some white matter signal abnormalities also. This was seen on CT scan in schizencephaly with large head. Often they have large head. There are two types of schizencephaly. Scissor means it cuts through the brain. So if it cuts through the brain, what happens? The gray matter lines the cleft. That is the differentiating point between a porencephaly and the schizencephaly. So see, these are gray matter line things, but they are reaching up to the ventricular surface, and the lips are closed like this, and it is bilateral. But they may be unilateral also, and the lip may be open like this. These are open lip communicating with the ventricles, and there is no septum pellucidum. Ventricle is dilated. This ballooning of the corpus callosum you can see. And this is unilateral open lip type. It was diagnosed by ultrasound previously. So very easy to see, and you see this gray matter lining is there. On T1 you can appreciate it better, this gray matter intensity. But this is another schizencephaly, but this is a porencephalic cyst. See, when it is porencephaly, it is not lined by gray matter. Here you can see it is lined by white matter, because this is a destructive cavity, cystic cavity. Some tumors are maybe congenital or developmental, you can say. One is epidermoid, which is easily missed, because on standard images they produce CSF intensity appearance. So here, only the expert eyes or experienced eyes will see that there is something over here. It is larger, but it is of CSF intensity. On all pulse sequences, this is T1 and this is T2. But see, on diffusion, there is bright signal. This is characteristic or hallmark of epidermoid, and this differentiates it from arachnoid cyst, which is CSF, purely CSF. Here it is not purely CSF. This is intracranial dermoid showing calcification on CT scan, and this is an arachnoid cyst. Very common location on the left temporal anteriorly. This is suprasellar. So whenever you see the dilated ventricles, you see another cystic area is there in the suprasellar region. So this is basically compressing the third ventricle and foramen of Monroe, causing hydrocephalus. And fourth ventricle is not dilated. You can see this fourth ventricle, it is not dilated. And at times this arachnoid cyst can be intraventricular also. This is an intraventricular arachnoid cyst. This is also producing hydrocephalus. At times they can produce epilepsy. This arachnoid cyst, because of some associated developmental disorder or due to mass effect or compression, they can produce. But the two things we always look for in epilepsy imaging is focal cortical dysplasia, and another is hippocampal sclerosis or medial temporal sclerosis. So focal cortical dysplasias are at times easy to diagnose and at times very difficult to diagnose. So earlier, one study we did around 15-20 years back in our institute, where we found at least 50% of the patients of epilepsy were MR normal. But nowadays it is not so. Because of the improvement in the equipment, the detection rate has gone higher, and statistically this refractory seizure patients who are not controlled by medication, in them 80% are neuroimaging positive. 80%. So focal cortical dysplasias are 3 types, 1, 2 and 3. Both are 1A, 1B, 2A, 2B, and type 3 lesions are associated with other lesions. So I am elaborating all these things. See, this is one type 1A. How do you differentiate? In normal eyes, you don't see much difference, but if you see asymmetric myelination, say this area is not myelinated, but this area is myelinated, this white matter. You should immediately look at the overlying cortex and this area. This is so subtle, this type 1A. This type 1 are basically lamination defects. That means the normal 6-layer cortex is not there. But there is no dysplastic neuron. In type 2, there are dysplastic neuron, abnormal neuron. So this is the essential difference between type 1 and type 2. In type 1, this is a white matter signal abnormality which pinpoints to the area of cortical abnormality. See, this cortex is abnormal, and it was confirmed by a SPECT study where you can see more perfusion. So this was type 1A. But at times you may get hypermyelinated area. This area is more myelinated. In the previous, it was less myelinated and appearing T2-weighted hyperintensity, brighter or T2. But see, here, this area, this is cortical dysplasia, but see, this is hypointense. That means hypermyelinated. So this can happen because of the postulated hypothesis is because of increased electrical activity of this epileptic discharge. Often the myelination process in that area is exaggerated or aggravated. That's why it is hypermyelinated. So this also, this asymmetry you should catch. Any abnormal cortex here? Just say on which side, right or left? Right. So this is the area of abnormality. So no, as this is primarily a disease of the grey matter, focal cortical dysplasia, because it is cortical dysplasia. But subcortical white matter is very important to see. So subcortical white matter here, you see that there is some amount of hyperintensity in the subcortical and cortical regions. That is actually catching your attention. So in FCD2, there are dysplastic neurons. In type 2A, the gray-white junction is irregular, and at times it is very subtle. I have deliberately kept this slide to show you that it is not very easy to pick up focal cortical dysplasia. See, this area, as because I have marked, it is easy to say that this cortex is thickened and this is not normal. And this is corroborated by here on thin sections on T1 weighted images. You can see there is subtle irregularity in the gray-white junction as compared to this cortex. But you have to train your eyes for that. But this type 2B, this is easier to diagnose because of underlying white matter signal abnormality, apart from thickening of the grey matter. Thickening of the grey matter and some amount of volume loss is there. You can appreciate there is enlarged CSF space over there. And it may be associated with calcification at times. So this was the area of abnormality, this one. And see, this is corroborated with the CT scan finding of calcification. On MR, this is the SWI image showing calcification darker. This is a large dysplastic cortex along with some agenesis and dilated ventricles. Like the cerebral hemispheres, cerebellum can have also cortical dysplasia. Cerebellum is often a neglected area in neurointerpretation. You have to see the cerebellum. Often the child comes with delayed walking and speech difficulty and other things. Especially for those, you must see the cerebellum nicely. Because there are subtle cerebellar abnormalities which can produce all these things. So this is a dysplastic cerebellum. There is an abnormal cleft here. And this cleft you can identify in other images also, here also. It is reaching up to the fourth ventricle. So this is a cerebellar cortical dysplasia. And your newer equipment, you can see another bigger dysplastic area. And you have to train the eyes in that way that these two hemispheres are not same. See the folial pattern here and there. Which side is normal, right or left? There is some difference between the right and left cerebellar hemisphere. Abnormal folial pattern is abnormal. It can give rise to some problem. On this side it is normal. This side it is normal. This side it is abnormal. Why? Because cerebellar folia always lies parallel to the calvarial surface. You see, this is the calvaria and this is parallel. And if it is perpendicular or in other direction, then that folial pattern is abnormal. If you look at here, this is abnormal folial pattern. So these are the things one should note. Next is hippocampal sclerosis or mesial temporal sclerosis. So in hippocampal sclerosis, the hallmark is volume loss and increase in signal intensity. So these two things are often there, often they may be alone. Like if there is only increase in signal intensity keeping the volume intact, that means it is hippocampal edema. At times the affected hippocampus may be larger. But if it is of small volume and with increased signal intensity, that we call hippocampal sclerosis. And additionally, there are some indirect signs. These are the indirect signs. Unilateral atrophy of the mammillary body. Mammillary body is a small thing in the hypothalamic floor. There are two mammillary bodies. If they are unequal, that means smaller on the side of affection, usually. And column of fornix, I am showing you which is column of fornix and class of fornix. Fornix will be smaller, parahippocampal gyrus and atrophy of the white matter. And overlying temporal horn, because of the volume loss, will be dilated in the side of hippocampal sclerosis. And loss of digitation along the floor of temporal horn, I am showing you. So, this is the temporal horn. CA2, CA3 means Cordua ammonis. This is another name of hippocampus. So this is CA1, CA2, CA3, CA4. 4 zones, they are divided. Because often the affection is partial, not the whole hippocampus is involved. So this is the hippocampal sulcus. Often this is dilated in case of volume loss. So these minute things you have to see. You can't report 10 MR in 1 hour in that case. This is the digitation. This is normal pattern. And when there is sclerosis, this digitation slowly fades away. And this is the parahippocampal gyrus. And this is the white matter we are talking about. Often it is atrophic in case of hippocampal sclerosis. So in abnormal here, this is the normal hippocampus and this is abnormal. See, the intensity is increased, overlying temporal horn is asymmetrically dilated, and there is loss of volume. See the area here and area here. You don't have to measure the volume. You can, by eye estimation, you can see this hippocampus is smaller in size and increased in signal intensity. So this is a left-sided hippocampal sclerosis. So these are actually foreigners, one of the class foreigners. So this class is seen relatively smaller on the left side because the left side is the affected side. Another quantitative methods are there. If you are not in doubt, you are not sure, then you can go for volumetry. And T2 relaxometry actually measures the T2 relaxation time, which one is really brighter. Often on eye estimation we can differentiate which one is brighter. And proton MR spectroscopy not really done in clinical practice, but can be helpful to see astrobiases here. Dual lesions may be there, as I said, in the type 3. So whenever you get hippocampal sclerosis, don't stop there. In focal cortical dysplasia, that there will be associated hippocampal sclerosis, associated heterotopic gray matter, polymicrogyria. Here also, dual lesions do exist up to 16-17% cases, up to. It can happen. So on this side of the affected hippocampus, you can see there is a small gray matter nodule in the subependymal region. So don't stop seeking more lesions. This is already you have seen Stark-Weber syndrome. The importance of SWI or susceptibility weighted imaging is you can see the calcification here nicely, as we see in CT scan, which is brighter. This is a CT scan, and in the earlier stages when there is no hemiatrophy actually happens later. First there is angiomatoses, which is the basic pathology. So if you give contrast in that stage, you can see this enhancement here. So that will give the diagnosis that there is some abnormal cortex there. Another thing is tuberous sclerosis. As you see, this is the Ashleigh macule, and these are the subependymal nodules. On T1 it is brighter, on T2 it is hypointense or less bright. These are the T2 weighted things. So these are the subcortical tubers or subcortical hyperintensity. These are the abnormal cortex. This is almost similar histopathologically with type 2B focal cortical dysplasia. This is another patient with tuberous sclerosis. You can see this subependymal nodule. So another triad of tuberous sclerosis, you know, one is Dr. Roy has told you. Another, epiloia, epilepsy, low intelligence, and adenoma sevicium. But unfortunately, adenoma sevicium happens in adolescent and onwards, not in smaller children. This is also a developmental issue, can produce seizure, is arteriovenous malformation. And this can present with hemorrhage. And on angiography, this is done without contrast usually. You can see the needles and the draining veins here. And this is another common finding is cavernous angioma or cavernoma. Often it is silent, no symptom. But at times it can produce seizure, and you can see the hemorrhage in different stages. And this popcorn type of things, this catchy fancy names are there. This is subacute bleed. So this is cavernoma or cavernous angioma. This child presented with a funny clinical symptom of sudden bursts of laughter. What is that called? Sorry? Gelastic seizure. Can you see anything here in the MR images or CT images? These two are the CT images and these are MR images. Yes, difficult to identify. This is from permanent magnet, at least 15 years back. So this is the thing. This is the lesion in the hypothalamus. So in a better equipment, you see this is so easy to diagnose. So this is the mammillary body I was telling. In from the mammillary body, pituitary stalk and pituitary. In this area, nothing should be there apart from some vessels. So if you see this area, anything other than these normal structures, you should scrutiny. This is a gray matter intensity lesion. So these hamartoma are usually small, maybe larger. If you give contrast, usually they don't enhance. So this hypothalamic hamartoma present with two things usually. One is gelastic seizure and another is precocious puberty. These are the two common presentations of hypothalamic hamartoma. So I think I have crossed my time. No, I didn't cross my time. No, nothing to show except to show you a nice lady. So black and white is even can be beautiful. This is a painting by my son who has just graduated from Kolkata Medical College. So this is his painting. I have kept as black and white memento. Thank you.
Thank you, sir. MRI using structural epilepsy. Let me call Anji, please come on the dais. To brief, sir.
Right.
Yes. Thank you, sir. During our PG course, I was the only neurologist from which we have learned that I see to have classes. And the most important issue is that for doing pediatric imaging, at moment it is very difficult to manage the patient, which can be done by sir and sir's team.
भाई एक पीछे नहीं
Now, prior to lunch, we have, this is the last session prior to lunch break. It will be totally a question answer based session. The topic is a case-based approach to re-enhancing lesions and differentials. And the speaker is Dr. Moshamle, who is a consultant neurologist from Woodlands Hospital. Why is he getting ready? I just like to share some experience. One of my friends was going out with me, had a history of unprovoked seizure, say around 7 or 8 years of age. And they took the best treatment. They have a CT scan. At that point, only CT scan was available in Kolkata. Nothing was found, but there were some problems in the EG, and he was put on antiepileptics. After a few years, again he had a repeat convulsion. Even after having proper medications in adequate doses, they changed the neurologist. They have a repeat CT, and they found nothing. In this way, when we were entering into adolescence and adulthood, he entered into engineering and IT medical professions. Nothing was detected. But by the time when I was an MBBS student, MRI came for the first time at Kolkata, and they did the MRI then, and they found there's a temporal sclerosis, which I was mentioned just a few minutes earlier. So the imaging modality is something which gives a clear diagnosis. During my early morning session, I told you that we have missed many diagnoses in previous years because we have no sophisticated instruments. But now, with the more and more higher Tesla and better instrument, we are able to take. And just keep in mind that after a few years also we will find there are lesions in autistic and ADHD brain, child brain. Today, what we say that nothing is detected in the imaging, but some problems happening. These are kind of neurodevelopmental diseases, so this will happen. So let us invite Dr. Mosamte and to start the session. Good afternoon. So after such beautiful presentations, so I am the only barrier between you and your lunch. So I will try to finish very fast. So what are the re-enhancing lesions? So as you know, there are lots of rings. There can be a simple ring, there can be ring with a diamond on it, there are various types of rings. In MRI also, we see lot of rings in that case. So I am trying to make it simple, little case based. So if you go online, you will see such lists. Sorry, I am not going to read it. Don't be afraid. So there are a lot of things. Abscess, infection, demyelination, congenital, neoplastic, miscellaneous, whatever you name, everything can show ring enhancing lesion. So this type of thing doesn't add it to our knowledge. Everything can have every appearance. Like our clinical presentation, every child can present in many a way. So coming to the common things which can present as a ring enhancing lesion. So this is a cerebritis abscess class of pressure. Whenever a child is present with a fever, so the clinical presentation is extremely important, otherwise we will miss the bus. In that case, what is the natural history of the disease? Initially, when the infection sets into the brain parenchyma, there is liquefaction, softening of the brain. In that case, we call it a cerebritis. So as I already explained how to identify the sequences. So this is the T2, as you know, CSF is bright, white. So just look at the lesion. This is a faint white lesion. Here also in flare sequence, lesion is faint. But look, whenever the cerebritis is converting into abscess, there is a clear-cut cyst-like thing with enhancing wall. That classic ring which we always discuss. But in cerebritis, the lesion doesn't look like that. It's ill-defined, infective, inflammatory-like picture. Whenever it gets liquefied, it becomes a ring-enhancing lesion. We call this as abscess and this as the cerebritis. The difference between encephalitis and cerebritis, we actually interchangeably use these terms. In this viral etiology, we call encephalitis. In case of non-viral, be it bacterial, mycobacterial, fungal, or free-living amoeba, we call it a cerebritis. So that's the basic. Now, this is a diffusion weighted images, and as we have seen multiple cases, this is showing diffusion restriction, and this is the ATC map, which should be black. Means it's a true restriction. Now, what is diffusion restriction? Just for simplicity, think diffusion means movement. Whenever we see an MR, it's a proton MR, but movement of water molecules. So if this room is empty, and if I ask you to run from this wall to that, so how fast can you do that? You will be quite fast. If instead of this vacant room, I fill the room with water and ask you to run, you will be little slow. And if I fill the room with mud, you will be extremely slow. So exactly, whenever there is a cyst with a clear fluid, it doesn't show restriction. There is no restriction of proton movement. But when it is abscess, it's a pass. Protons cannot move. Diffusion will show you are right. That's the basic pathology, basic concept. So this cerebritis abscess group comprises a very common cause of ring enhancing lesion. After this, we have the infective etiology. Most of the things have already been shown by SAS. So the next slide I think is some infective etiology. Tuberculoma or NCC, as you know, every day and night, every radiologist have tried throughout their life how to differentiate between them. It's difficult. The classic presentation is easy, but many times we always in a doubt, is it a tuberculoma or is it an NCC? Many times it's very, very difficult. So both tuberculoma and NCC, if you look at the natural history of the disease, they develop, then there is a ring enhancing lesion, edema, and ultimately heals with a calcified granuloma. So if it is a healed lesion, nobody can tell you what was it. It's a tuberculoma, NCC, or maybe something else. If it's a healed lesion, you cannot say what it is. But in classic situation, we might differentiate tuberculoma or NCC. But as I already told you, many of the newer sequences, why we need those sequences? Because from the conventional sequence we are unable to diagnose. That's why we need a newer sequence, otherwise there is no need. So to differentiate between tuberculoma and NCC, we have a lot of sequences. Like magnetic transfer sequence, there are big names. Don't be afraid with the names, big names. So many authors have tried throughout their life, there are thousands and thousands of publications. But in many of the situations, believe me, you cannot differentiate between NCC and tuberculoma despite all your best efforts. So I'll show you some classic images. Luckily we have got images. So this is a tuberculoma case which I was showing. You can see there are a lot of, this is a classic ring, this is a solid ring, various types of rings you can see, and this is after the ATD onset. Look, there is significant resolution of the lesions. Number of granuloma has reduced significantly. So this is a classic tuberculoma. The only thing, the ring is T2 black in tuberculoma. But obviously it doesn't hold true in 100% of cases. It's a classic presentation. This is obviously after tuberculoma, as Sir was telling in his presentation, it should be NCC. So we have to respect that. So you can see there are a lot of dots inside this cyst. White cyst, inside there is a lot of dots. So these are the scolex, as we know. So this is a very florid case. In most of the situation in your lifetime, you will get this type of cases quite rarely. The classic, most commonly we get this type of cases. There is a non-specific ring, no scolex, what to take? Every time you see the report is tuberculoma / NCC or granuloma, like that. So yes, sir, what about sir? So in most of the situation we cannot differentiate. So there is nothing to be ashamed of. Nobody can do that. So this is, here you can see there is a classic scolex. Very rare. Scolex is very rare. And in most of the situation, this is a ring enhancing lesion, no scolex. There are ways to differentiate. In tuberculoma, as Sir has already said, the size criteria, the edema. In case of NCC, there are different stages. I am not going into those details, but various stages appear in the same time. Say for there will be some ring with a lot of edema, there may be a ring without any edema in the same ring, the same time. That goes more in favor of NCC, but very, very difficult to differentiate. Coming to septic emboli, there might be a source of infection somewhere else. Say for example, a child has an bacterial infective endocarditis, congenital cyanotic heart disease. Just look, here in the superior cerebellar vermis and the cerebellum, there are a lot of lesions. So there are infective deposits. They just behave like an infective focus in the brain. So septic emboli you have seen in lung also, the same concept. It can spread to brain. It's a septic emboli of the CNS. Let's shift to a different pathology. It's a 19-year-old guy who has presented with a large mass, supratentorial mass. From this image, everybody can understand it's a supratentorial mass with a cystic lesion outside. And look, this is the MR spectroscopy. So we know this is a mass. For confirmation, MR spectroscopy gives us a little hint. Different peaks, NA, choline, these peaks appear. MRS is there to help you. If I give you a single MRS and say what's the diagnosis? No, you can't. Nobody can't. You need a basic T1, T2 diffusion layer and GRE, what I was saying. You must need this. After that, if you need, then go for spectro, DTI in rare instances. Most important is T1, T2 diffusion, GRE and obviously contrast. So this is the diffusion tensor imaging which Dad was already saying that it will tell you nowadays. Say for example 20 years back, if a radiologist has diagnosed there is a mass in supratentorial, this area, that area, every clinician was happy. Nowadays it's not the scenario. Our surgical team has improved a lot. Now they are going to cure this child by surgery. So they always want to ask, is the pyramidal tract involved in the mass? That's the question. Everybody knows. Even the patient can raise the film and say, yeah, I have a mass. So what's the point of a radiology? So DTI will tell you whether the surgeon will go in for operation or not. If after removing the mass, the child is significantly neurologically damaged, then there is no point of doing a surgery. So So MR has gone age ahead. It's not just a diagnosis, you have to prognosticate. Coming to some other lesions, so everybody can see the fourth ventricle, there is a mass in fourth ventricle. So in pediatric age group, as you all know, there are basically 4 to 5 masses in the posterior fossa. So I don't know what it is. So how to go ahead? You might feel very proud. Yes, there is a mass in fourth ventricle, I know. What is it? Look here. The mass is actually passing through the foramen of Lucian. So whenever a mass is plastic nature, means it passes through different foramina, it goes more in favor of ependymoma. It's a classic presentation. Here the mass is not in fourth ventricle, but it's in the brainstem. Entire brainstem is involved. In pediatric age group, it's a brainstem glioma. Third, just look what Sarah was saying, it's a white. So it's a tissue sequence, it's a white fluid. And just by the sight of the fluid, there is a white thing, but it is not that white. So this is a solid component. You can see in the contrast, the solid component, this part of the white is showing enhancement, and the actual brighter white portion is not enhanced. It's a solid and cystic component of the mass. In pediatrics, posterior fossa, solid cystic, most common is the pilocytic astrocytic. This is the common things. Uncommon things occur very frequently, don't worry about that. But I'm telling you the common things. Again, just like the first slide, there is a fourth ventricle region mass, but it is not passing through any foramina. So let's have a more common thing, medulloblastoma, which is quite common in the posterior fossa in a child, and a rarely very close mimic of medulloblastoma is an atypical teratoid rhabdoid tumor, very difficult to differentiate from medulloblastoma. Just look, presentation. Clinical presentation is very, very important. I will show you a live case. I will feel how important it is. So this is a 10-year-old girl presenting with fever, pain, difficulty in walking. What is the imaging you will do? Any of our pediatric students? From this, no, MR of this, MR of what? MR of spine. Any abnormality? Look, in the cervical cord, there is altered. I am not saying describe, just altered signal here. It's a white, it's abnormal. And obviously, don't restrict yourself to spine, because in spinal lesion in child, demyelination is very common, and whenever there is demyelination in spinal cord, you have to image the brain, because there might be some focus in there which might not have manifested. So we did, and there is some amount of hyperintensity in the peri-insular region on left side. So this is a case of demyelination. Demyelination also might enhance sometimes, not always. So this is a young girl who presented with fever, and after fever there is backache followed by weakness. So whenever there is limb weakness, we image spine. See again, there is hyperintensity. So this is also a case of demyelination. So in between infection, mass, and all these things, don't forget demyelination. It's a quite common cause of pediatric. It's almost companion case, you should say. And here there is a demyelination in brain. Now see, here the demyelinating focus is enhancing. Every time it doesn't enhance, but it might enhance. This is showing diffusion restriction also. This is also rarely seen. And in follow-up, almost significant resolution of the plaques. So that itself indicates this is a waxing waning type of disease, goes more in favor of demyelination. Another companion case. Okay. So here there is again abnormal spinal cord in the cervicodorsal region, but there is some white signal change around the fourth ventricle. What Sarah was telling just a few talks before, that between the third ventricle and the fourth ventricle there is a cerebral aqueduct of Sylvius. So this is the aqueduct of Sylvius region in action. So there are some peri-aqueductal altered signal. This is very classic of NMO, neuromyelitis optica. In this case, you have to image the orbit of the patient, brain and entire spine. So you never know where the lesion is. There may be multifocal lesion. There is brain, the orbit, in any part of the spine. So you have to image the entire neuroaxis. This is called NMO, and this very aqueduct region is very important. So if you have your anatomy clear, getting the MR is not a difficult job. So before the live case, the last slide means tumefactive demyelination. Sounds good? Tumefactive demyelination. So is it a tumor or demyelination? It's a demyelination. Looks like tumor. So don't get biased. Look at this image. Everybody will say, oh, there is a mass in this chart. There is a mass with some enhancement. So demyelination also enhances. But classic tumefactive demyelination shows incomplete ring enhancement. So this is not a complete ring. This is the almost we can say 120 degree of the circle is enhancing. So it's an incomplete ring enhancement. We call it tumefactive demyelination. So we get a little bit of idea about ring enhancing lesion, and sir has already given you a brilliant idea of the anatomy. So if the computer permits, let's have a few live cases. So if any resident can try, no harm in it. Maximum you will fail. What's wrong in it? You can practice if you wish. So anyone? So this is a T2 sequence. And in the posterior fossa, in the left cerebellar hemisphere, there is a cystic thing. Something water filled. So what sequence you want next? This is a T2. There is a cystic thing in the left cerebellar hemisphere. So let's see the diffusion. It's a resting. Cyst. Diffusion resting. We were discussing in a protons will not move inside pus, it will show diffusion restriction. So let's see how it looks in post contrast. Now everybody agrees it's a ring, complete ring, looks like ring at least. Most of the lesion don't look like ring exactly. So this looks like ring. So this is the case of abscess. Many things can mimic. So always go by the history. History and clinical presentation in neuro is most important. Forget about your MR. From the history itself, examination itself, you know there is a lesion in that part of brain or spine. You know that. MR is just to help you a little. Clinics is the most important. You cannot forget that. So this is the case of abscess, cerebral abscess. Anybody? This is the T2 sequence, as you know, CSF is white. So this is the T2 sequence. Sir has already shown this presentation. This is hydrocephalus. Already you have seen, this is hydrocephalus. Why? There must be a cause of hydrocephalus, compressive hydrocephalus. So it's a compressive hydrocephalus, non-communicating. Okay. Good. Already you have given a correct answer. Just for formality, I am showing you the contrast images. Answer is correct. So this is some part of the lesion is solid, enhancing, some part is cystic. It's a T1, so water looks black, and it's a pilocytic astrocytic, classic presentation. In this case, there is an enhancing solid mass in any of location, resident. Sir has already told you. No, location. I know there is a mass. Everybody knows. The patient can raise the film and say there is a mass. No point to tell them. Okay, left basal ganglia. Okay, good enough. But just look one thing. Sir has also pointed out another anatomical landmark. This area is called foramen of. The two lateral ventricles join Monroe. The mass is actually ruptured into foramen of Monroe. So you cannot limit yourself, there is a mass. Everybody knows there is a mass. The mass is ruptured into the ventricle. So your entire surgical plan changes. You have to image the entire neuroaxis, the entire spine you have to image now. So don't restrict and don't satisfy yourself just by saying a mass. It is called satisfaction of search. Whenever we get a finding in anything, be in a bedside clinics or image, we get satisfied. Okay, chalo ek diagnosis to mil gaya. Fail to nahi hai. We get satisfied and we use the second diagnosis. So this is a mass. and it has ruptured. That portion you have to see. Another last case. Listen. So, I am showing you all the sequences in this case. This is a young lady, 12-13 years age, presented with weakness of the limbs. So, there is something in the right frontal white matter, some altered signal. Means some abnormalities there. I myself also cannot say anything beyond that from T2. Okay. Good, we have found something. Let's see the flared sequence if it adds to our knowledge. Not much. Again, some altered signal intensity in that area. Any special sequence you want to see? So let's see the GRD. Means it will tell you if there is any bleed, if there is recalcification, if it is there or not. Let's see. No black spots out there. So there is no blood, there is no calcium. Let's go to the pointers. So let's see the diffusion. So diffusion, okay, there is no restriction, There is a significant amount of diffusion restriction, and I am telling you it's a restriction. I have checked the ADC. So diffusion restriction it's not a focal diffusion restriction. You can see these dots are also restriction. What could it be? It says, is it a stroke? We have a very good session of stroke early in the morning. Is it a stroke? Patient is saying little bit of weakness, no fever.
Brain abscess.
Okay. It could happen. If the patient takes a lot of over-the-counter antibiotics, TB might present without fever also. TB can present with anything we know. Okay, tubercular abscess, good enough. Any more sequence you want to see before concluding? This is my diagnosis. Contrast. Let's see. How does it look? Sorry, this let's see that area. Contrast. Subtle enhancement, not very confident. There are other images also. Let me see once. Yes. Look. Will you tell anything? I don't know how well you can see this. There are some nodular enhancements. Anyone want to change your diagnosis from tubercular abscess? Ring enhancing nodules. Abscess के अंदर तो nodules usually नहीं होना चाहिए. हाँ? Don't worry. It's a very difficult diagnosis. Tell. Cystic granuloma. So nodular enhancement, granuloma. Then how will you explain that diffusion restriction? You have to explain it. Huh? No, in case of tuberculosis, the most common complication is infarct, and that is more common in pediatric. In addition, there may be myotic aneurysm, this, that, but infarct is very common in pediatric with tuberculosis. So can it be a tuberculoma with infarct? More common diagnosis? I also thought in that direction also. Okay. Now let's see the angio. This is the right IC. This is the left IC, right IC. Same caliber. Significantly altered caliber. Everybody can see. Now the right IC showing supraclinoid ICS still narrowing. Anything? Want to change your diagnosis? And I will show you this one. So this is the left NCA territory, this is the right NCA. Definitely asymmetrical. Anybody can see it from a mile distance. So this is the case of Moya. And that nodular enhancement was subacute infarct. So I was joking of that slide. We will not teach you in that way, but now go through the slide. Subacute infarct can show enhancement. So you have to assess the entire thing. Just there is a nodular enhancement, tuberculoma, NCC. In your real life situation, many times you will see it will not help you. So subacute infarcts can also enhance, and the moya can present in such a way. I also thought कि nodular enhancement है, diffusion restriction, चलो tuberculoma with infarct. It's a common diagnosis. In your scenario, that's a more common diagnosis. Moya is a rare thing. But these rare things come rarely and will surprise you. So that's the end of the thing. I tried to end the talk with that case only. That's a difficult case. So let's enjoy the lunch now. Thank you. That leptomeningeal enhancement was also there. Dr. Sudhita pointed out. I thought it was a very technical one. Actually, it's a what should I say? Wherever there are a lot of collaterals, viral collaterals. What was that? So it's definitely
So thank you, Dr. Mosham, for taking the conversation. And now we'll have our lunch break and we'll start again from 2 p.m. onwards. And once again, I welcome you in the post-lunch session. We are left with two important discussions. The first one will be the traumatic brain injury, reviewed perspective by Dr. Somen Das. And subsequently, we have a video presentation that is from Dr. Nimal Rai, who was unable to present here due to professional reasons. And after that, we'll hand over the certificates to all our participants. So, may I now call Dr. Somen Das on the dais.
Good afternoon, everybody. Thank you for inviting me for this talk. Today I will be talking about the imaging in traumatic brain injury from the radiologist's point of view. So the outlines is going to be the background, the imaging modalities which we do, the primary lesions, the secondary lesions, and clinically how do we predict the prognosis by imaging. So this is the risk factors, the extreme age, male, low socioeconomic status. There has been an error, sorry for that. The GCS 13 to 15 is mild HI, head injury, 8 to 12 is moderate, less than 7 is severe head injury. So the types of head injury are whether it is open or closed injury. The closed is whether dura is intact, and the open is whether dura is disrupted. Now the intact dura is due to the violent accelerations like contracoup and hook injuries, and the Open injuries are due to fracture and foreign body, and penetrating injuries of the dura. Now, after the head injury, there are two types of lesions. There are the primary or the secondary lesions. The primary lesions are caused by the trauma itself, and the secondary lesions are due to the response of the brain to the trauma. So the primary lesions can be intraction, extraction, which will go in detail later. The secondary lesions are due to the trauma itself, which the brain responds to the trauma, like compression on the cranial nerves, blood vessels, skull, dura, the herniations, diffuse edema of the parenchyma, and infarctions. The goals of imaging are to rapidly diagnose the kind of trauma the brain has undergone. For that, first and foremost is the CT. Now, some abnormalities, the brain responses, but we do not find anything in the CT. Then we go for the MR. The prognostications of the injury are by clinical findings, first CT, then MR, and advanced MR techniques. Now, why do we do CT in traumatic brain injury? First of all, it's widely available. It's a faster scan time, lesser scan time, and which, suppose we have any neurosurgical interventions, it can be decided whether the surgical or medical management is to be done. When is to be done? It's the moderate or severe closed acute head injuries, minor acute closed injury with risk factors, obviously children, penetrating injury, skull fracture, to rule out vertebral or carotid artery injury. How do we do it? We do non-contrast axial scans, minimum 3 meter slice thickness. We always do a bone algorithm and reformations in the 3 planes, axial, coronal, and cervical. Now there are, if you see other findings from the brain, suppose we have a maxillary hemisinus, we do a facial CT. We have a skull base fracture, we consider CT angiography and skull base deformations. If there is cervical spine fracture, we do a cervical spine CT. How to interpret the CTs. Do not forget the primary lesions and obviously the secondary lesions. Because if the study is near normal, we have to look for the secondary lesions. Find tooth injury and the contratooth injuries. Check the areas where there are contusions and diffuse axonal injury. Diffuse axonal injuries are many times are normal brain. We check in the interpeninsular fossa for small subarachnoid hemorrhage. Now what about skull X-ray? Are we doing it? Yeah, not very frequently, yes, but we are doing it. In some cases of penetrating injury, radiopaque foreign bodies, and part of the skeletal survey. Sometimes, if you see the traumatic brain injury, you do not have any skull fracture. In negative skull fracture, X-ray, do not forget to do CT. Obviously, in the 3 planes, the X-rays are done. Obviously, X-rays are obsolete now, but still, frontal, lateral, and counts need to be done. Now, the role of MRI is it optics, obviously more sensitive for primary, secondary injuries, better differentiation of hemorrhagic and non-hemorrhagic lesions in the acute phase. However, there are limitations of MRI. Suppose the patient in the senior, obviously the cardiac pacemaker is a contraindication, ferromagnetic and foreign bodies. Obviously, the MR has lower sensitivity for bone fractures and hyperactive blood. And there is difficulty in managing trauma patients in MR suit because of the metallic life supports and monitoring devices which may not be compatible for MR, and obviously the time. The MR takes a longer time to study. Coming to the classification in the pediatric brain injuries, calcareal fractures are the first things we look for: intraction lesions, extraction lesions, abusive head trauma, which are very common in the children, birth injuries. anatomy of the skull, there are three layers. Obviously, we know the outer table, the diplo, and the inner table. The parts of the skull which are without a diplo are very prone to fractures, like the squamous temporal bone, parietal bone, foramen magnum, skull base, pubiform plate, and the orbital groove. The types of skull fracture, there are three types, 3 or 4 types: depressed, linear, skull base, and open head injuries. Linear fractures are sometimes associated with extradural and subdural hematomas. Depressed fractures, we get parenchymal lesions like contusions. Here you see the two images. On the left is an X-ray with CT reformatted. We see a linear fracture involving the parietal bone and the frontal bone. On the right we see a linear fracture involving the parietal bones with CT in the bone window and 3D reformatted images. Here we see the depressed fractures of the scalarium. The depressed fracture, obviously the brain parenchyma looks normal over here. Sometimes we get confusions. Here we see the depressed fracture with scalp hematoma and contusions in the parenchyma. And then we have the skull base fractures involving the sphenoid vein, libus. So obviously we need bone algorithms for the traumatic brain injury. Usually the skull base fractures are the extensions of the skull base fractures are usually the fractures which are extensions of the cranial rod. The clinical clues are the CSF rhinodia, hemotympanum or laceration of external auditory canal, ecchymosis, periorbital ecchymosis, and direct orbital trauma, especially bilateral cranial nerve injury is seen. Now there are some mimics of the skull fracture, which are the sutures. How do we differentiate them? They are usually the fractures are smooth, which is jagged edge. The sutures are serrated edges. Usually the fractures form a linear straight line with an angular turns, but the sutures are curvilinear lines and turns. The fractures are greater in width, sutures are lesser in width. In X-rays, the fractures are loosened, the sutures are sclerotic. So that's why I said darker and lighter. A little bit about the diastatic skull fracture. It is usually the separation, traumatic sutural separation along the suture line. So usually affects the knee bones and infants with confused sutures. Usually unilateral. Most commonly seen as the lambdoid and the sagittal sutures with more than 2 mm separation, which is asymmetric. So we have to compare it with the contralateral side. There are some images. We have the CT informative images, which is gaping of the sagittal suture with a fracture with more than 2 mm separation. We call it a diastasis. Here we see the frontal contusions, the scalp hematoma, and then again the frontal contusion. A little bit about the activity called pneumocephalus. What we know is that air within the cranial cavity is called pneumocephalus. Sometimes in acute traumatic settings, there is commonly due to the fractures of the PNS and the temporal bone, that is open skull fractures. They do not cause immediate danger. The rapid expansion of the air within the skull can cause tension pneumocephalus. looks like a Mount Fuji. So it's called the Mount Fuji sign. Usually it decreases within 10 to 15 days and almost never present in 3 weeks. Coming to some of the interaction injuries which we commonly come across. First and the foremost is the diffuse axonal injury. So the mechanism of injury is traumatic acceleration and deceleration or violent rotation of the child's head. So there may be immediate loss of consciousness, or patient can go into trauma. This most severe of all the primary brain lesions can cause permanent vegetative state. Clinical symptoms are usually worse than what we see in the CT. Sometimes we can see normal CT. It can be associated with subdural, subacute hemorrhages and fractures. Most of the cases, the diffuse axonal injury in acute setting will be non-pathologic. You will not see anything in the brain. If you will see small leak in the gray-white matter interfaces, sometimes in the corpus callosum and sometimes in the dorsal membrane. CT is not so sensitive sometimes to find out about which is basically a diagnosis of exclusion, not so sensitive CT. So, if the patient's imaging and the clinical findings do not match, we need to go to MR to rule out diffuse axonal injury. And the location and the number of lesions predict the prognosis of the patient. In the top row, we see the normal CT without anything, no hemorrhage, nothing. But when we go to the MR, we see small hyperintensities in the white matter, gray-white matter interfaces. These are the diffuse axonal injuries. Some more images, MR images, where we take blood sensitive sequences, like gradient sequences, where we see tiny blooming artifacts, that's what we call, which are suggestive of microbeads in the gray-white matter interfaces. This is how the diffuse axonal injury looks like. The CT is a normal insert cases. So there is clinical as well as radiological grading of diffuse axonal injuries. So grade 1 injuries occur within the lower white matter in the gray-white matter junctions. Grade 2 injuries including the lower white matter plus involvement of the corpus callosum with involvement of the body and the spleen. Grade 3 injuries involve the white matter, the corpus callosum with additional involvement of the brainstem, often involved in the rostral brainstem, to distribute a cerebral metastasis. When initial brain CT is normal for the patient, clinical condition do not match with the CT findings, we need to do an MR with blood sensitive sequences or follow up in the CT after 24 hours. In 1/6 of the cases, VAI will evolve. Next interaction lesion which is very common is confusion. The mechanism is obviously cerebral parenchyma impacting the inner table of the skull. There are obviously two and the contributive injuries. There are 3 types of confusions: petechial hemorrhage of the thyroid, small hemorrhages of the large hematomas. Again, the confusions evolve over the time of the 24 hours. Early, it can be early non-hemorrhagic, then it can progress to acute bleed within the parenchyma in the next 24 hours. Here again, some of the images, hemorrhage intraparenchymal confusions in the frontal lobes, intraparenchymal hematomas in the frontal lobes, temporal lobes. Obviously, we have to look at the opposite side, where the primary injury has occurred. So this patient had primary injury of the skull with the skull fracture and the contact injury in the frontal lobes with hemorrhagic contusions. MR is again more sensitive to the blood sensitive sequences like gradient, which shows renal artifacts, appears black in the cerebral parenchyma, cerebellar parenchyma into the primary trauma, which showed the normal or total hyperdensity on the CD, which we can conclude on MR there was a bleed. There is a small speck of tentorial circular hematoma also. Repeat the image again. Hook and the contour injuries. The hook injury was a small cerebellar contusion with a skull fracture, and the contour injury was a frontal contusion with a small speck of tentorial circular hematoma. Other interactions are interaction lesions that can be traumatic intraparenchymal hematoma, interventricular hemorrhage, traumatic lesions of the deep brain matter and the brain stem. They can be simple hemorrhages. Coming to the more common extra-axial lesions, which are the extradural hematomas. So the dura attaches to the sutures. So the epidural leads are confined to this, but do not cross the sutures, with some exceptions obviously. The mechanism is due to the failures of the epidural arteries like the meningeal artery or the veins, or due to trauma to the dural venous sinus. It's again associated with the calvareal fractures. Sometimes in the children we see hematomas without any calvareal fracture. There is an entity called venous epidural. Venous epidural crosses sutures due to the trauma to the dural venous sinus. Here we see a few images of the epidural hematoma. Epidural hematoma is usually lentiform shape. There is an associated fracture of the calvarium. There is an associated scalp hematoma with calvarial fracture. Type of epidural hematoma is called venous epidural hematoma, where the epidural hematoma can cross the suture. Usually epidural hematomas do not cross the sutures because dura is adherent to the suture. In this case, the epidural hematoma, in this patient a contrast study was done. The scar showed a dural venous sinus, and outside the dural venous sinus we see an epidural hematoma. This is the epidural venous epidural, where it is outside the dural venous sinus. Next more common entity of after the epidural is the subdural. Subdurals are the outer margins of the outer margins of the cerebral or cerebellar hemispheres. Usually they are crescent shaped, and they can cross sutures but do not cross the midline. They extend into the interhemispheric fissure or extend along the temporal. The mechanism is due to the injury to the cortical bridging veins as they traverse the subdural space. Here we see subdural hematoma, which is along the cerebral convexity from the parietal convexity, which is extending into the tentorium. So these subdural do not cross the midline, they extend along the tentorium or the pars. Another patient with a subdural hematoma. This kind of hematoma is due to the multiple phases of bleed. Some are acute, some are hyperacute, some are subacute. So the attenuation of the blood is in the various stages, which is obviously causing the mass effect. So here we see the two types of the primary lesion is the subdural hematoma, and the secondary lesion is due to the consequence of the primary lesion, which is the midline shift, subcalcine herniation, diffuse edema. So the interpretation of the CT is by interpreting the primary lesion as well as the secondary lesions of the which are consequence of the primary lesion. Coming to subarachnoid hemorrhage, obviously subarachnoid hemorrhages are within the subarachnoid space appears hypertense along the sulci. It is important to properly window the image to see a subarachnoid hemorrhage. Here we see the subarachnoid hemorrhage, which is seen along the hypertensity along the sulci, the sylvian fissure, which is extending within the ventricles. Obviously, a small speck of subarachnoid hemorrhage is also seen in the CT. There is an entity called pseudo-subarachnoid hemorrhage. It's actually the diffuse parenchymal edema where the brain appears hypodense. Consequently, the vascular engorgement occurs with replacement of the CSF and the cortical edema, which causes the diffuse hypodensity within the brain parenchyma, which is actually not acute. In the pediatric age group, we see sometimes elusive head trauma. Elusive head trauma, the consequences of the calvarial fractures, subdural hematomas and convulsions are very common. When you see multiple type of injuries in the brain, there is a fracture, there is a chronic subdural, there is a calcine subdural, there is a fracture, obviously we need to see the elusive head trauma. Again, another case of elusive head trauma with multiple types of injuries in the calvarium as well as the brain. There is a subdural hematoma. There is a subdural hematoma. There is a subdural hematoma in various stages. There is an acute and there is a chronic subdural. In elusive head trauma, another entity is called shaken baby syndrome, where the baby is shaken vigorously. And it was posteriorly for various ways of acceleration and deceleration on the brain parenchyma, with relatively large subarachnoid spaces in the brain for the scaling of the breathing veins and the resultant subdural hemorrhage. This is how a bridging vein looks like in MRI. We see a sign called tail of a tadpole, where there is a focal clot in the bridging vein with disruption of expanded and thrombosed bridging vein, which is the tail of the tadpole. And disruption, the clot is the head with the black arrows. You see the subarachnoid spaces. Another consequence of abusive brain trauma is the hypoxic ischemic injury. This is in watershed distribution injury and less commonly focal or venous focal injury or venous infarct. Subdural hemorrhage is also seen. Diffuse axonal injuries of all the seen in abusive head trauma. Injuries to the cranial-cervical junction, injuries to the cervical spine, extracranial injuries of the metaphyseal lesions and great fractures. This is a case of abusive head injury where we see a subdural, acute subdural in the subdural hematomas in the various stages. Now again we see a diffuse parenchymal edema where there is replacement of the sulci and the diaphragm. So this is the hypoxic ischemic injury. Another case of abusive head trauma where there is diffuse parenchymal edema, the stars, which is hypoxic injury with chronic subdural, acute subdural. this case, there is cystic encephalopalacia changes in the deep in chronic submucous. In another case of post-hypoxic injury and evidences of trauma. A few words about the birth-related injuries. The birth-related injuries can be subdural, laticular, subarachnoid hemorrhages, calcaneal fractures, extracranial injuries like scalp hematoma, calcium subdilated hemorrhage, and first few entities we have spoken about. The calcaneal injuries, the scalp hematoma, the caput, the subdilated and the hematoma, and the lesson we described about. Caput subcutaneous is referred to the scalp hemorrhage, superficial to the gallopneumatosis. So, if you are spread throughout the scalp, it can cross the midline, since it is not bound by periosteum or an aneurysm. Most cases are usually self-limited. A subgallal hemorrhage is between the periosteum and the overlying gallal aneurysm. This can also cross the midline and extend into the soft tissues of the neck. Most often with instrumentation in the ventricular birth with rupture of emissary veins. Again, self-limiting, which results in a few weeks, large hemorrhage may be expensive and symptomatic. Nephromatoma subperiosteal hemorrhage. Between the underlying calcaneum and the overlying periosteum. This is due to the increasing speech of prolonged labor and neutralization and instrumentation. Since it is subperiosteal in location, these hemorrhages are confined by sutures and do not cross the bottom. And usually they are firm in consistency. Sometimes they can calcify over time. So this is hematoma is below the periosteum. So this is the hematoma below the periosteum, which has calcified over time. So here we see the various birth injuries within the scalp and the gallia aponeurosa. This is subgallia aponeurosa, is the gallia aponeurosa, subgallia aponeurosis, subgallia hemorrhage, which can cross the midline. Extragallia, there are two. There is gallia aponeurosa, the subgallia hemorrhage, and there is the Concluding the presentation, we have cross-sectional images plays an important role in identifying and characterizing pediatric head injuries. The key differences in children arise from the complexities of the brain, developing brain and calcaneum, and the unique mechanism of injury, including the head trauma and birth injuries. In the cases of the pediatric head trauma, we assist the pathologist in appropriately evaluating full spectrum of injuries, including diagram of markers of life.
Thank you, Dr. Somen Das, for a deep description on traumatic head injury. Now I'd like to call on stage Dr. Nidhi to present Dr. Das. So now we're moving to the last session of today's workshop, and that will be on demystifying white matter diseases of brain and how it can MRI approach. Dr. Nirmal Rai has sent us a wonderful video.
That I am not a very good afternoon to all of you. I am extremely sorry that I am not being able to be present in this conference physically. this is a very complex set of disorder that I have been given the responsibility to cover. So I will start with what is white matter and what is grey matter. White matter of the brain and spinal cord is composed of bundle of axons, as all of you know. These are coated with myelin, which is a mixture of protein and lipid that helps conduct the nerve signals and protect the axon. White matter job is to conduct rays and send nerve signal up and down the spinal cord. While the grey matter, named for its pinkish grey calories, form two neural cell bodies, axon terminal, dendrites, as well as nerve synapses. It is abundant in the cerebellum, cerebrum, and brainstem. It also forms a butterfly-shaped portion of the central part of the spinal cord. So, first thing you need to know is how the grey and white matter looks on MRI. So, as you all know, there are three basic MRI sequences: T1, T2, and clear. Just remember that grey matter always looks grey on all the sequences. But white matter appears hyperintense compared to the grey matter on T1 weighted images, hypointense compared to the grey matter in the T2 weighted images, clear, which is basically a T2 weighted image with fluid signal intensity or CSF signal intensity in some place. In that also the white matter appears hypointense. So this is a T1 weighted images. You can see that the putamen and the caudate, which represents the grey matter, is appearing grey, but the posterior lobe, internal capsule, subcortical white matter, these are appearing hyperintense on T1 weighted images. On T2 weighted images, again, the putamen and the caudate nucleus, these are appearing grey, but the posterior lobe, internal capsule, that is subcortical white matter, they are appearing hypointense. On clear, it is similar, that is the putamen and caudate nucleus are grey, while the posterior lobe, internal capsule, and the subcortical white matter are hypointense. So first, I have divided this talk into two parts. First, I will discuss the neurodystrophic and the different inherited metabolic conditions, and then I will briefly cover the demyelinating pediatric demyelinating diseases. So first, I will start with the neurodystrophic and the inherited metabolic conditions. So these are very diverse group of brain disorders associated with the mutation which leads to production of an abnormal protein that impairs the function of one or more metabolic pathways. These are called neurometabolic disorders because these metabolic disorders have significant neurological implication. Sometimes the disruption of metabolism affects the individual brain development, resulting in a malformation. Much more typically, the brain forms normally and individual does not begin until sometime after the birth. So these are associated with profound embryonic changes in neonatal and infantile stage, while in juvenile and adult age the milder diatomical phenotype is present, presenting signs and symptoms are usually non-specific, non-reactive, acute, subacute, or slowly progressive. Imaging studies most often suggest a certain type of disorder, impaired development, focal or degeneration or infantile injury, but related to this diagnostic. Biochemical tests may be normal or non-specific, while genetic analysis are often unrewarding unless a specific genetic defect is suspected and solved. As a result, 40 to 50% of children with newborn errors of metabolic never receive a specific diagnosis. It is important to organize this disease from an imaging perspective so we can offer some treatment. So first we need to know some definitions of terminology. The term leukodystrophy refers to all genetically determined disorders that primarily affect the central nervous system white matter irrespective of the structural white matter component involvement in molecular process affected and the disease course. While the term leukoencephalopathy means secondary involvement of the CNS white matter due to a systemic disorder, genetic or acquired. And the term polydystrophy means predominant involvement of the CNS grey matter, while dystrophy means mixed involvement of CNS white and grey matter. Now these are the different another sets of terminology that you should know with regards to abnormal white matter signal. The first term you should know is delayed myelination, where the maturation of myelin lags behind the age expected. It is common and a non-specific finding can be caused by several factors, both systemic and neurological, may be reversible. The term hypomyelination refers to persistent paucity of myelin, where there is an arresting myelination process and there is mismatch occurs between the T1 and T2 signal intensity. The term dysmyelination refers to deposition of abnormally composed fragile myelin which can easily break down. The term vacuolating myelopathy refers to delayed brain iron and water hemostasis, which leads to chronic systemic and edema, like megalencephaly, leukoencephalopathy, or acutely restricted and potentially reversible diffusion changes as occurs in maple syrup disease, where water trapping happens in the myelin interlaminar spaces. Now the term demyelination refers to secondary loss of myelin, which may be previously normal or abnormal. It is an end-stage process in multitude of different processes, including dysmyelination or other demyelinating conditions where myelin is damaged by toxic materials, infection, ischemia, or trauma. The inborn errors of metabolism can be divided into many groups. So this can be broadly divided into disorders of carbohydrate metabolism, which include these diseases like glycogen storage diseases, disorders of amino acid metabolism, which includes the different alpha-proteinuria, hyperlipidemia, immunity disease, glutamic aciduria, and nucleoside disorders. Also, other diseases include lysosomal storage disorder, that all of the new pediatrician must be knowing of, and the disorders of paroxysmal function or disorders of mitochondrial functions like disease, mitochondrial encephalomyopathy, lactic acidosis, stroke episodes, etc. But it is important to divide these diseases from a clinical point of view. This can be practically divided into following groups, that is the disorders of energy production, disorders of biosynthesis and catabolism of complex molecules, disorders of intoxication, amino and organic acid disorders, and neurotransmitter diseases. So in the disorders of energy production, there is insufficient production and utilization of the energy, and there is multi-system involvement, typically affecting the heart, brain and skeletal muscle. Example is mitochondriopathy, fatty acid oxidation disorders. In disorders of biosynthesis and catabolism of complex molecules, there is abnormal production or breakdown of complex molecules which is built up in organisms such as lysosome or paroxysome. Slow but irreversible progression of symptoms and usually do not present perinatally. Neurotransmitter disease tend to present as severe encephalopathy and rheumatic results like pyridoxine and pyridoxal deficiency or non-ectopic hyperglycemia. Disorders of intoxication like amino and organic acid disorders leads to accumulation of endogenous toxic compounds proximal to the block in the metabolic pathway. Usually an initial symptom within interval of hours or days after burning is encountered. Acute exacerbations may be brought on by fever, internal and illness or the pattern of damage may be quite specific and can provide clues to the underlying causes like glutamic aciduria or metabolic disease. Other amino acidosis and organic aciduria are comes under the classification of this group of disease. So the clinical presentation in the neonatal period can be vague, like symptoms such as vomiting, hypotonia, seizure, while in the later phase acute and recurrent attacks of generalized symptoms such as ataxia, vomiting, acidosis of time, seen. Chronic diseases present with developmental delay, motor symptoms, polytechnic, non-regression, epilepsy, psychiatric manifestation that can present anytime from birth to adult. Non-neurological involvement of other systems such as cardiovascular, dermatological, endocrinological, and others often leads to the diagnosis. So as I have already said, that clinical presentation can be very often vague and protracted mode of clinical presentation depending on pattern recognition alone is often insufficient to characterize a particular disorder. The indication of clinical data using abnormalities allows recognition of the most specific physiological patterns. Therefore, knowledge of some clinical data is often important for the neuroradiologist involved in the diagnostic workup and follow-up of the patient with suspected or confirmed neurometabolic disorders. These patients almost always appear normal at birth as the toxic substances are eliminated by the placental circulation. Symptoms begin to appear after a variable period of time, maybe days, weeks, months, or years, as the metabolite accumulates. Acute presentation is mainly pneumonitis and generally they manifest as both pain and lethargy, sepsis, and patient in the age group. Think of an inborn error of metabolism, routine investigation like blood test, culture, history, normal patient is not responding to the standard treatment. Maintaining a high index of suspicion for inborn error of metabolism is typically to the So these are the points when you should suspect an IgM environment, that is a symptom-free interval followed by clinical deterioration, presenting with signs of encephalopathy, unusually normal blood parameters, blood cultures or other baseline investigations, certain onset of illness after certain types of intake or unusually severe reaction, infection or metabolic stress, family history of such as parental consanguinity, unexplained previous neonatal death, dysphotic features or multisystem involvement, unusual motor. The muscle tone changes can help in medical diagnosis in these shapes of patients. When a patient presents hypothermia, it is generally because of impairment of energy or metabolism, like mitochondrial disorder or paroxysmal disorder. In non-ketotic hyperglycemia, also can cause hypertonia or have an initial effect of calcium on spinal and motor. Hypertonia is typically noted with diabetes and methylmalonic acidemia. Osteoporosis is present seen in macrocystic stroke or stroke-like presentations can be features of some IgMs and that can be related to acute stroke, which can be or stroke-like episode. Some organic acidopathies like chromonic, isotonic, and hyaluronic acidemias can present due to intracranial hemorrhage, coagulation, abnormality, thrombocytic. Ischemic complications, that is, or in lysosomal storage disorders, others have these things or stroke-like events that will follow and relapse. Motor delay is more observed hypomagnesemia as opposed to motor degradation, white matter diseases, that is early and prominent inherited type, while gray matter diseases, those types are late. Early and prominent white matter diseases, gray matter diseases, microcephaly declining seizures, dystonia, choreoathetosis, other features of gray matter involvement, while prominent optic or peripheral neuropathy may be associated with white matter diseases, but not with the gray matter diseases. Retinal diseases, gray matter diseases, generally gray matter diseases doesn't accompany any neuropathy. So these are some specific clinical examination findings which can often help us narrow down the diagnosis. Like I will not discuss this in very detail, like I am just specifying the condition of macrocephaly. If you see a macrocephaly child and there are other suspicions of IgM, so these are the very few sets of disorder that can present with macrocephaly. So we can that is the clinical note. You can see the MRI in that right of the clinical note and narrow down diagnosis. Similarly, other abnormalities, chemical abnormalities, hearing loss, helps point out the diagnosis. Some of these organic aciduria and other diseases have some characteristic orders that the pediatrician must be aware of. So these are the first line of investigation, that is the blood, sequencing, complete metabolic profile, urine analysis, pH, color, odor, specific gravity, ketones. These are the first line investigation that is done in suspected cases of IgM. So these are the differential diagnosis of neuropedicon disorder presenting as acute encephalopathy, and these have various biochemical properties as you can see in this case. So now coming to the MRI-based pattern approach. So white matter disorders are basically classified based upon the subcellular structure involving for their specific metabolic pathway disturbance. MRI-based pattern approach is practical and especially important for unresolved leukodystrophy. It does not always work because a lot of diseases are nearly identical in limiting feature, particularly in later stage of the disease. Most useful when correlated with other clinical features and in the early stage, but not immediately after the onset of the disease. So we have to first see whether it's a white matter disease or a gray matter disease. So if it's a white matter disease, then the first step in diagnosis is to exclude delayed myelination. If delayed myelination is excluded, then the next step would be to exclude hypomyelination. Then we should exclude patchy demyelination. Then we should see the distribution of the leukodystrophy demyelination, and then we should do specific imaging that I will be discussing in the subsequent section. So the step one is to exclude the delayed myelination. To exclude the delayed myelination, it is very important to know the normal steps of myelination or how the normal myelination happens. So the most paramount important is the knowing the gestational age of the child, as the maturation of white matter follows a rather specific pattern defined by the age. Maturation of myelin appears complete on T1-related images by the age of 1 and on T2-related images by the age of 2 years. So if the maturation of myelin is behind the schedule and concordant on T1 and T2-related sequences, delayed myelination should be reported. So just remember this thing, how normal myelination progress. Normal myelination progress from proximal to distal, central to peripheral, posterior to anterior, and the central areas are first myelinated, followed by the motor areas. On imaging, the myelination is characterized by shortening of the T1 and T2 time, reduced diffusion, increased diffusion anisotropy, and increased magnetization transfer. So these are the selected myelination milestone that we should be knowing of. Very important that we remember this table, and often these tables are keep as just beside the reporting areas that we can compare. And then the normal MRI atlas that is available online also as per the age, that also you can remember. So this you can see, this is the actual T1 case, a normal 12-month one. Shows the pons and cerebellum, those are got have a near hyperintense appearance. The pons and the middle cerebellar peduncles, as you can see, has almost myelinated. However, if you see here, the white matter in the temporal lobe is largely unmyelinated in this region. So, the hyperintensity in subsequent images, these are the images you can see, it extends into the Q fibers, as you can see here in this region, it extends into the Q fibers as the child progresses. So this table you should remember or keep beside for reference. Step 2 is to exclude hypomyelination. T2-weighted images in hypomyelination will demonstrate a slight hyperintensity of the white matter relative to the cortical perimeter. On T1-weighted images, it may be hypoins or hyperintensity, but by and large, there is a frank discordance between the expected T1 and T2-weighted signal of the white matter. Hypomyelination can be differentiated from delayed myelination by obtaining a follow-up MRI. 6 months after the initial one, increased myelination will be seen in disorders with delayed myelination, but no change will be seen in patients with hypomyelination. So these are the hypomyelinating disorders. Most common are hypomyelination of unknown causes, or the Fording syndrome, Pelagian multifocal disease, and Pelagian multifocal live disease. So I'm going to show a case of hypomyelination. This is a 4-year-old girl with a significant motor and memory delay. As you can see here, this girl has some hypogonadotrophic, hypogonadotrophic and hypotonchia. We can see that there is T2 hypointensity in the region of optic tracts, as well as in the pyramidal tracts, in the posterior limbs of the internal and anterolateral gyrosarami. Together with there is cerebral atrophy. Mild cerebellar to white matter hyperintensity are noted, which are characteristic, and this child has a typical problem with the dentition, that is, there is a hypotonchia. So a diagnosis of 4H syndrome characterized by hypomyelination, hypogonadotrophic, and hypotonchia was made. Another case you can see here is a 4-patient with a 4H syndrome and Pelagian multifocal live disease, which presents typically a week later than the Pelagian multifocal disease. Patient presents with a regular eye. So here what you can see is there is a NAD in the MR spectroscopy sequence, because the NAD is not remembered but it has function. The excess NAD binds to glutamate to form NAD glutamate, which is not absorbed from MR. So we can see an MR spectroscopical peak, and there are also pyramidal tract and pointine hyperintensity that is not in the Pelagian multifocal disease. This is another case, patient with a hypomyelination with a congenital cataract, presented with at the age of 2 months. Subarna biopsy was done. We showed reduced or absent myelination. You can see in this area there is no myelination in the periventricular white matter area. Now coming to the step 3 is to assess the pattern of leukodystrophy, that is exclude patchy demyelination. Initially the white matter should be assessed to determine whether the involvement is localized, multifocal or diffuse. Localized white matter involvement is generally noted in inflammatory demyelination, autoimmune enteritis or radiation injury. Asymmetric multifocal white matter involvement typically suggests autoimmune or inflammatory injury or unusual genetic disorders such as polyglucagon body disease or hereditary diffuse leukoencephalopathy with neuroaxonal steroids. So whenever we see the involvement, disorders with predominant white matter involvement, we should see whether it is involving the subcortical white matter or it is involving the deep white matter. So if it is a subcortical white matter involvement, then we should see whether there is a frontal white matter predominance. If it is frontal white matter predominant, we should suspect Alexander disease, frontal variant of X-linked ALD or neuronal leukodystrophy with steroids. If it is posterior white matter predominance, then we should suspect classical forms of X-linked leukodystrophy or Graves' disease. Contrast enhancement, if we see, it is characteristic of ALD, Alexander disease and Graves' disease. Now, the disorders with early involvement of the deep white matter. So, in such cases, we have to answer 3 questions: whether there is calcium in the thalamus, whether there is short T1 or short T1 in thalamus, whether there is pons, medullary or corticospinal tract involvement, or whether there is brainstem involvement. So, if thalamus is involved, then suspect Graves' disease or the GM1 or GM2 gangliosidosis. If thalamus is not involved, then the next thing should be seen whether there is pons, medulla or corticospinal tract involvement. If it is involved, then we should suspect X-linked adrenoleukodystrophy, giant axonal neuropathy and acyl-CoA oxidase deficiency. These are the differential diagnoses. If it is not involved, then we should look for if the differential diagnosis becomes a big and it includes MLD, phenylketonuria, hyperhomocysteine, leukoencephalopathy with vanishing white matter disease or paralytic white matter disease, Lowy disease or Sjogren-Larsen syndrome. Now, the next question we should answer is whether the brainstem is involved. If brainstem is involved, then we should suspect Maple syrup urine disease and the juvenile Alexander disease. Here, corticospinal tract in pons or medulla was involved. Here, the brainstem structure is involved. That I will discuss in the subsequent slides. So, in this case, as you can see here, there is hyperdense bilateral thalami, and as you can see, there are abnormal signals in the bilateral thalami and the posterior limb of the internal capsule. There is a very small NAT on the mass spectroscopy, and this case was diagnostic, as there is thalamic involvement, was diagnostic of Graves' disease, which is a lysosomal storage disease characterized by galactocerebrosidase, beta-galactosidase deficiency. There is psychosin accumulation in the globular cell, which is highly toxic to oligodendrocyte. Clinical issues these are more common in female. There are 3 forms that are described. Infantile is the most common form, juvenile and adult forms are relatively rare. So on non-contrast CT, the features we see are basal ganglion, thalamic hypertensity or sometimes calcification, coronal radiata, ventricle also can involve because of the globular accumulation and calcification. On MR, there is periventricular white matter and corticospinal tract hyperintensity. Thalamic T2 hypointensity and T1 hyperintensity, which corresponds to the higher accumulation on the CT. Remember, the subcortical U fibers are spared. There is alternating halos around the dentate nuclei that you can see in these images. Optic nerve and chiasm are often involved, and sometimes the other area nerves can also become involved. So, if optic nerve and chiasm is injured, most of the time we should suspect a diagnosis of Graves' disease. Obviously, characteristic thalamus and other structures also need to be involved. So, Graves' disease, we have found that if diffusion tensor imaging are done, then fractional anisotropy and anisotropic halos are significantly lower around the entire length of the corticospinal tract and the genu tract in the caries patient. Now coming to the next disease, this is next case of Graves' disease. The evolution of Graves' disease in a patient, as you can see, the involvement of the corticospinal tract bilaterally as well as involvement of the thalamus and posterior of the internal capsule. This is how the disease progresses. The signal intensities are increasing and involving the perimendibular white matter location also. Now coming to gangliocytosis. So there are two diseases, GM1 and GM2, Tay-Sachs and Sandow disease, as you all know. They are biochemically distinct but clinically indistinguishable, can have an infantile, juvenile or adult form. Infantile form is characterized by post-facial and skeletal dysostosis, and hepatosplenomegaly juvenile feature form is associated with psychomotor retardation, while adult onset occurs slowly progressive dystonia and ataxia as well as extrapyramidal signs. So again on NCCT we will be seeing an hyperdense thalamus. T1 can be hyper and hypo or hyper. On Tay-Sachs disease, on T2 the ventral thalami are hyper, but on Sandow disease the dorsal thalami are hyper. So in Tay-Sachs it is the ventral thalamus, in Sandow it is the dorsal thalamus that is involved. The white matter appears variably T2/flare hypertension, no enhancement. DWI may show variable reduced diffusivity in ventral thalami in cases of Tay-Sachs disease. So you can see here, this is the ventral thalamus involvement, this is the dorsal thalamus involvement in the Tay-Sachs disease and Sandow disease respectively. Plus you can see other areas of altered signal intensity in the white matter. Remember, there is no cerebellar involvement or no optic nerve involvement as we have seen in the Graves' disease. So that is how we can differentiate between the Graves' disease and the gangliocytosis. So this is another case of leukodystrophy. You can see that frontal white matter is totally spared. Slight hyperintensity is noted in the corticospinal tract forms and involvement of the subcortical fibers are noted. Here you can see that hyperdiffusion restriction is cranium of the corpus callosum as well. So this becomes again in our differential diagnosis the part of the disease that we are discussing, the early involvement of the white matter. So I think most of you know the diagnosis. This is a case of metachromatic leukodystrophy, which is a lysosomal storage disorder because of decreased ARSA, which leads to fibrolytic aponia. This is the most common inherited leukodystrophy. It has again got three forms: infantile, juvenile, and adult. On imaging, it appears to show the centrifugal spread of demyelination, starts in corpus callosum spherica, extending to direct occipital white matter, frontal temporal white matter affected later, spares the subcortical fibers and cerebellum. Classic butterfly pattern can be seen in some cases. As you can see here, the classic butterfly pattern, symmetric hyperintensity can be noted around the frontal horns and the atria of the bilateral lateral ventricle. Tiger pattern, stripes of peripendular myelin sparing the white matter and lipid containing glial cells may be seen in some cases like this. In some of the cases of metachromatic leukodystrophy, it is also found in gadolinium. Then you can see enhancement along the cranial and the coronary nerves. So this is a scoring pattern that is used for extent of the metachromatic leukodystrophy disease. So this you can remember. So this is the original research article formation to fit. So there are a few differential diagnoses of metachromatic leukodystrophy that we should consider. One is the Graves, where the thalamus, cerebellum, and optic nerve and plasma is more common. Periventricular white matter injury can also be noted in history of lobar torticollis cellular clinically static diabetic or quadriplegia patient, or because of some cerebral complications. And other differential could be vanishing white matter disease, where we can see gravitating pattern of urine. coming to the next disease, you can see here there is again extensive white matter signal, basically bilateral segmental white matter. But when the follow-up MRI was done, you can see there is accumulation that is happening in the areas of white signal. The disease has progressed with accumulation and the vanished white matter has vanished, leaving some black holes in the pattern. So here the diagnosis of leukoencephalopathy with vanishing white matter should be considered. It was mentioned that this is also called childhood ataxial diffuse central nervous system hypomyelination of cash. Typically have normal development in early childhood, then develop progressive ataxia, spasticity with releasing pneumatic series. Development of bulbar symptoms can occur. Variable optic atrophy and epilepsy can happen. Episodic retardation is often associated with systemic illness, trauma or emotional stress. Pre-leukoencephalopathy is an especially severe rapidly progressive form of white matter disease that affects and with the use of scan management and is invariably fatal by 21 months of age. The diagnostic criteria, these are the diagnostic criteria that has been proposed. So in that imaging, MRI should show bilateral symmetrical cellular and systemic white matter signal intensity which is similar to CSF. So for diagnosis to be made, all the four criteria should be identified. That is the neurological criteria as well as the MRI criteria has to be fulfilled. So these are the obligatory criteria for looking at diagnosis of this vanishing white matter disease. These are the suggestive criteria of looking at diagnosis of vanishing white matter disease. Again, the differential diagnosis should include Alexander disease, which but that will show macrocephaly. I have already pointed out that whenever you see macrocephaly, Alexander comes into differential diagnosis. There is no history of episodic neurologic deterioration in the Alexander as noted in vanishing white matter disease. There is a frontotemporal Alexander and frontal white matter disease that is noted in Alexander disease is noted in the late stage of the disease. Clinically, vanishing white matter disease can resemble flat disease, but there is no thalamic or cerebellar involvement in vanishing white matter disease. And the other disease that comes into very close differential diagnosis is the megalencephaly leukoencephalopathy with subcortical cyst, but that will be again characterized by large head cell. Course of the disease is mild and not episodic. Cysts are located in the subcortical location rather than in the periventricular location. Lateral elevation in this condition. So, now coming to the next condition. We are in the same group of disorder where the pons medullary and controspinal tract is not involved and there is early involvement of deep white matter. We can see there is involvement of the bilateral white matter. This child has lipopigmentation and musky order of the lungs and skin and hair. So as you can guess, the diagnosis is of anemia, which is the most common form mirror of amino acid metabolism caused because of hydroxylase deficiency. Neonates are often asymptomatic, fair skin, blue eyes are very common, non-specific signs, symptoms like eczema, developmental delay, seizures, and hyperactivity can be seen severe mental retardation and global developmental delay result of the disease is untreated or if deep dietary program restriction is not followed. Patients are characterized by mass dyscalculia and hyperallergenia. Early treatment is to minimize the cognitive impairment. Dietary restriction of meats, nuts, vegetables, starchy food should be done. This is a case of anemia. But also at the same entity. You can see there is different white matter signal changes in the bilateral, periventricular white matter or periventricular as well as the subcortical white matter location. And there is mild contrast enhancement as well. This patient of blood inflammation was found to have an elevated homocysteine. So this was a case of hyperhomocysteine. We are just saying this is of disease as metastatic hyperhomocysteine and hyperhomocysteine apnea is also not only multidisciplinaries, metabolic resulting elevated plasma osmosis, which is normal at part. It is often characterized by dislocation of the limbs, osteoporosis and kyphoscoliosis, can occur both arterial can occur at all ages. An important cause of stroke in young patients is next disease. This patient, as you can see, there are multiple cyst-like structure, multiple prominent PGIPS cases in bilateral treatment is that associated with congenital cataract of retardation behind tubular dysfunction, which often used to article these dilated perivascular space confluent with level which does not involve the subcortical fiber but only involve the peripheral matter. So this is a classical case of oculocerebral renal syndrome or Loeys syndrome, which is an X-linked recessive disorder characterized by phosphatidylate 4,5 bisphosphonates, phosphatase deficiency that is located in Golgi complex. It is characterized by the already discussed congenital cataract, convolution retardation, renal tubular dysfunction, metabolic mobility, artery. Coming to the next set of diseases, as you can see, the extensive white matter syndrome is a ventricular white matter as well as the splenium of the corpus callosum is involved and the contrast enhancement. So we are dealing with the next set of disease, that is where there is pons medulla corticospinal tract involved, that is the X-linked anteroleukodystrophy, giant axonal neuropathy, and extensive oxygen deficiency. As you can all understand, is a classical case of anteroleukodystrophy, which is a paroxysmal disorder characterized by extensive deficiency. There is an impaired oxidation of the very long chain fatty acids, which leads to severe inflammatory myelination. 3 zones of inflammation noted, including Barnum, both myelination and inflammation, peripheral demyelination, inflammation, clinical issues where there can be few data, classic HCA, most common form, boys, presenting deteriorating cognition and school performance, and the second most common form, most common communication, and those development can occur in 20% of the patients. The imaging features are very characteristic as there is posterior predominance in 80% of the cases. Earliest finding is this linear involvement. It spreads from posterior to anterior center to the periphery. The intermediate zone of demyelination often enhances and restricts variant pattern of XCTH anterior predominance observed in 10 to 15% of the patients. And with the adrenomyeloneuropathy, because corticospinal tract, cerebellum and motor and initially white matter and elastic distribution absent. In MRIs, we can see reduced DNA, one disease myeloaneurysm and reacted tablet. Here you can see the classical enhancement pattern of the disease problem. So this is the case of another case of AD. To start with the splenial hyperintensity. However, 8 months later, the dysmyelination has progressed with the intensity post-contrast demyelination. This is the case of anteroleukodystrophy. Pattern, you can see there is involvement of bilateral frontal bilateral as well as there are cortico-pontine tract and corticospinal tract involvement are also noted in the brain. So if you see enhancement, which is very characteristics of anteroleukodystrophy, but it has got some differential diagnosis as usual. So if you see enhancement, the possibility can include Alexander disease or Kolkata disease. These are the differential diagnoses of enhancement, but Alexander disease is In Crab disease, there will be posterior cerebral halos are alternative as I can be seen. Enhancement also can be seen as a prominent feature of Crab disease. Other causes where enhancement can be seen are hypocalcemic injury, like where cortical deformity can be seen, no enhancement, and posterior hypocalcemic LSBF, I will discuss this topic later. This can also show enhancement, but these are not certain diagnostic and clinical criteria. Coming to the next set of disease where there is extended content, increased activity of the nerve chain, alpha-ketonic acid dehydrogenase complex is noted and studied with classical indicator initially normal within days after birth during splints of mechanism syrup or burn sugar, immediate post-perfusion started was to ratio and excellent outcome. This is one of the key that can probably diagnose ultrasound, where transcranial ultrasound shows hyperlipogenicity Thalama whether interface cerebella into or cerebral intensity can be involved in cerebral self-penetrating cerebral peduncular thalama vascular posterior internal capsule internal medial and tegmental the region emerged correspond to those that are myelinated or myelinated at the time of birth. PWI or PGI can show distinctive diffusion that indicates that they are hyperlipogenicity. A classical 4-dot brainstem scan can be seen. MRS at 0.9 during caused by from branching data to amyloidosis can be noted. So as you can see here, there is dark of the brainstem and the pons. Addition, there is involvement of the thalama in bilateral vascular and here you can see this is the classical 4-dot sign, 4-dot brainstem sign. There is pathological treatment. So, even though there is this type of information on the brainstem, cortical spinal or cortical pontine can always suspect branching and disorder like pathological disease. So now coming to the disorder, the there is a subcortical multilateral having a large head, there is suspected if there is a normal head cell, it is suspected keratocyte or system without hydroxybutyric acid Negative subcortical cyst is also known as renal disease. It is caused by NLC1 mutation, autosomal recessive disease. It is distinguished from other neuropathies by its remarkably slow course of neurologic deterioration and the onset of common. The magnitude of abnormality is much worse than the huge subcortical bystander is typical. Effective subcortical bystander is reported of you can see there are subcortical cyst formation with extensive bystander symptoms effective bystander. So the differential of disease includes canavan, which also has pre-hospital but earlier onset and Alexander has already discussed contact with the 6 and if you come to the issue of bacteria, Coming to Alexander, I have already discussed differential diagnosis of various other disease. It is a fibrinoid leukodystrophy caused by internal dominant functional Z-type gene. This cause precipitation and accumulation of mutant intermediate brain of infant with elevated market. Astrocytic density and porosity entrance. Rodental fibers in astrocytes and histopathological hallmark of elevated disease can be clear with the motion of less than 2 years presently mechanically progressive realization and seizure. Older patients will have anesthesia conversing complaints with normal diagnosis of elevated disease Microcephaly will be used as a classical medicine that lateral finding of the related disease and the concept which appear shoulder and hyperintents. Changes in most severe cases in bilateral frontal region. Moderate to striking enhancement can be seen on post-contrast images. Reform images can be seen on the surface of the shoulder body affected frontal lobe. In the juvenile and adult form, brainstem and cellular involvement can be striking and significant. So here you can see the classical finding of T1 hyperintense mean around the bilateral lateral ventricles. And then despite high MRI feature by the diagnosis of elevated disease can be made extensive program documented with frontal neurons abnormalities of the resultant abnormality and contrast of the more of the criteria for an MRI-based diagnosis of elevated disease. So this is actually a long-term type of elevated disease. Here you can see the area side hyperintensity, and some marks. So that also can be a presentation of the elevated disease. Juvenile form of elevated disease, there is some enhancement in the cerebral. The brainstem involvement, as I have already discussed. So there is enhancement and often involves a biomarkers. So please keep the diagnosis of elevated disease, particularly you see the other features of the Now, this is a spotter type of case. This is a 22 year as you can see, the MRI images as well as bilateral and last there are some particular classifications also. So this is a classical case of lymphatic PGIPS syndrome. Do not confuse this with lymphatic syndrome. And those are two different intensity. Lymphatic syndrome is more of a malformation syndrome and lymphatic PGIPS syndrome is more of a leukodystrophy. Another case, we are going for delay. So it is the typical case of open has got other right? Retinitis pigmentosa and mental retardation. Now I will briefly discuss the disorders that involve the dominant gray matter only. So if the disorder involves the gray matter, we have to see whether it is involving the cortical gray matter or not. If it involves the cortical gray matter, then these are the four diagnoses that we have to consider: neuronal ceroid lipofuscinosis, Brady syndrome, mucolipidosis, and Alport syndrome. So So neuronal steroid lipofuscinosis is a accumulation of the steroid lipopigment inclusions in the neuron. These are again classified into infantile, juvenile, and adult form. Now classified according to the age affected gene. Histopathological features are abnormal accumulation of DAS or sugar gland positive inclusion in the brain neurons. There will be progressive atrophy and thin cortex with enlarged ventricles, periventricular hyperintensity, and are prominent cell size. So the brain will look more like a brain of an aged person in neuronal steroid lipofuscinosis. So if there is this prominent deep play matter involvement, then we have to see whether there is a striatal involvement or covascular involvement. If there is striatal involvement, then the disease into Huntington disease, creating deficiency syndrome, Day syndrome. Short attitude or hypointensity in covascular, we should consider neuropathic brain iron accumulation and oculodental dysplasia. So Huntington disease, as you all know, is an autosomal dominant disease. The most characteristic loss abnormality is the volume loss of the quadridigenous glutamin and the covascular, as you can see here. Cerebellar atrophy can also be seen. Glutamin involvement is more common in Huntington's. So in juvenile Huntington disease, we have to see the frontal bone to be CC ratio and increase then that is statistic of the qualitative. So this is another classical spotted type of case. So the brain MRI is subtly abnormal with mild hyperintensity in the globus pallidus. But if you do EMR spectroscopy, it shows there is a reduced creativity. So this is a case of a creatine deficiency syndrome, and this is characterized by this L-arginine aminotransferase and guanylyl methyl transferase enzyme deficiencies. Coming to Wilson disease, this is an abnormality in copper metabolism, and all of you must be at the sake of time. I am just progressing with the imaging characteristics. As you can see, there are hyperintensity of the bilateral supranuclear, bilateral thalami, as well as the substantia nigra, which is called the Dan Mata sign, as well as there is a miniature Mata sign, and there is a light rostrum sign. So these are the signs that are typical of Wilson's disease. Another case, there is gross hyperintensity in the cerebellum as well as bilateral basal ganglia and thalamus, and there is elevation of the lipid acid lactate also in this patient. So this was a case of Leigh syndrome. So these are in Leigh syndrome, there is bilateral symmetric areas of motor signal in the basal ganglia. Glutamina is the most consistently affected, as are the podated dorsal thalami most commonly affected, is less commonly affected. Mid and lower brain lesions are typical in Leigh syndrome, and young cases can be the only findings. Symmetrical lesion in the cerebral peduncle are common, and periapical gray matter is frequently affected. Acute lesions show restriction, but these lesions do not show enhancement, and on MR spectroscopy you can see lactate peak at 1.3 ppm. So these are the different deficiencies that can present with features of Leigh syndrome. Another case showing the cerebellar peduncular hyperintensity as well as the convulsivity. Now coming to the MELAS, these are caused by point mutation in mitochondrial DNA characterized by clinical triads of lactic acidosis, seizures and short-term lipids. Choke can be associated with cardiac abnormalities, renal dysfunction, GI motility disorders, and general muscle weakness. Abnormal mitochondria have been found in the arterial also of MELAS species, including a masculine etiology. Mean age of symptom onset is generally 15 years. Imaging findings can vary with the disease acuity. Acute MELAS often shows swollen T2 or severe hyperintense diarrhea, cross vascular distribution, territories that is like a typical infarct which doesn't follow an arterial territory. Parietal and occipital lobes are most commonly affected. Appearance of strokes in different diseases occur due to the diagnosis of MELAS. Chronic Miller shows multifocal lacunar type infarct, symmetrical megakardia, classification, white matter glomerulus, and progressive atrophy of the palatal cortex. Nearly two-thirds cases of Miller's have a prominent lactate doublet at 1.3 in otherwise normal appearing brain. So this is a typical case of Miller. As you can see, there is some acute infarct like diffusion restricting lesions in the right parietal and right occipital lobe. That carrying hypointension, that is hypointension on the ADCM. But the MR angio looks absolutely distinct, and there is a lactate doublet. You can see here, it's a diagnosis of Miller's can be made. Coming to the next set of disorder, as you can see here, there is T2 shortened bulbous paradigm. So these are the cases of neurodegeneration of the brain iron accumulation, which includes this group of disorders. As you can know, this is the Hallerborn-Spatz disease of the classical Neuropedicon. This has this eye of the Alzheimer's sign. MRI scan show decrease NAP and reduce NAA to creatine ratios consistent with a neuroaxonal loss. Increased bioenergetical peak can be seen, but this typical Hallerborn-Spatz disease, typical eye of the tiger sign is noted. And you can see vacuolation in the anterior lobus pallidus also. However, remember, in time as the disease progresses, the eye of the tiger due to hyperintensity shrinks and becomes less conspicuous. Neuropedicopathy is more of a adult onset disease, so I won't discuss it in detail. So eye of the tiger sign can be seen or not seen. Infantile neuroaxonal dystrophy, it is more or less characterized by the striking cellular atrophy in an infant. In abnormally, almost 50% of the cases demonstrate abnormal iron deposition with T2 hypointensity in lobus pallidus and substantia nigra, and it spares the cortex. Coming to the next entity, 35-year-old female, though although not pediatric, just for the sake of discussion, you can say very hypointensity in the signal in the bilateral dentate nuclei, bilateral putamen, bilateral thalami, as well as in the bilateral red nuclei. Patient has a triad of diabetes, the symptom. So a diagnosis of aceruloplasminemia is made in this patient. Now coming to the disorders that are affecting both grey and white matter. So if it is involving the deep grey and white matter involvement, there can be three patterns that can be seen. If it is involving the primary thalamic, then the diseases should include Krabbe's disease, GM1 or GM2 gangliosidosis, Wilson disease, and succinate delight deficiency. Most of the things are already covered. Primary globus pallidus is involved. Then these are the list of disease that should be considered: Canavan's, methylmaloniacidinemia, L2 hydroxyglutaric aciduria, fucocytosis, nucleocyclic disorder, and maple syrup urine disorder. Some of them have already been discussed. And last is the primary striatal involvement. If it is seen, then the diseases can be leg disease, Miller, Wilson, Alexander, propionic aciduria, glutaric aciduria type 1, molybdenum cofactor deficiency, 3-methyl glutamic aciduria, biochemical deficiency, biochemical responsive mesothelioma disease, and cocaine disease. So Canavan disease is a very famous lipodystrophy. It's a fatal autosomal recessive disease due to the aspartoacyl deficiency. There is intramyelinic edema and myelin damage. It's a congenital disease, or it can be infantile, which is the most common form, seen in the 3 to 6 months of age. Fatality presenting hypotonia, hypotonia, and seizures. Death happens by 1 to 2 years of age. Developing form, death actually noted in 4 to 5 years of age. It has a milder course. So as you can see in this image, basically there is diffuse tissue or white matter hyperintensity, and there is basically no myelin that can be seen, and there is a characteristic NAP which is virtually diagnostic of the Canavan disease. So in Canavan we can see virtually complete absence of myelination, which subcortical arcuate fibers are initially affected. There is a diffuse volume loss in the late stage. There is no enhancement. MRI shows markedly elevated choline to creatinine ratio is also markedly elevated NA. is the characteristics of Canavan disease. Please know that it is a very diagnostic of Canavan disease, and according to creatinine ratios reduced in Canavan disease. Again, that the differential diagnosis will again come for the Alexander disease, Neuroradiology, Kolkata, and religious multiplier disease that we have already discussed. Now coming to urea cycle or ammonia disorder, these are the list of diseases that can happen and show the characteristics. One. So remember, as ammonia crosses blood-brain barrier, it is converted to glutamine and leads to some oxidative stress which causes astrocytic swelling. Typically have intermittent neurologic dysfunction that may present as movement disorder, seizure, axial lethargy or confusion like insular cortex, developing cortex, show hyperintensity and swelling. Peninsular cortex is affected first, extending progressively to frontoparietal, and lastly occipital lobe. Characteristic of brain involvement and motility, subcortical white matter is involvement and early. Cerebral involvement is often slightly asymmetric. Lactic and of glutamine and glutamate resonances can be seen in this type of disorders. So as you can see, there is characteristic of the peninsular cortex, region, as well as the cortical area. Now another case where typical deposition of the bilateral robust system is a case of methylpantonic acidemia. Cystic changes occurs with bilateral robust plus there can be periventricular white matter signal changes and sometimes delayed myelination or small dilated brainstem or cerebral can be noted. Another case, 11-year male with a global developmental delay. There is a gradient from the periphery to the center, anterior to the posterior, and the subcortical white matter is involved as well as the bilateral robust and the cerebellar nuclei are involved. So there is some subtle diffusion restriction in this area. So this was a case of L2-hydroxyglutaric aciduria. This is the autosomal recessive disorder. It is again shows this pathognomonic MRI finding we have already been discussed. The characteristic MR spectroscopic finding is called 2-hydroxyglutaric because 2-hydroxyglutaric acid. It can be seen in some of the patients, and because it is associated with cerebral neoplasm also in some cases because it is one of the excess 2-hydroxyglutaric acid that get accumulates in this disease, which can be mild neurotoxic as well as can be carcinogenic. Now coming to glutaric aciduria type 1, it is an autosomal recessive disease. There is the accumulation of glutaric acid in case of vascularization during the third trimester and post-bacterial used to vascular intake and particular degeneration. Child generally present at the first year of their life with acute encephalopathy, seizure, dystonia, choreoathrosis, vomiting, and testosterone. Hypoglycemia can be accompanied by elevated and organic acid. So there are three signature imaging findings. First is the macrotenia, then is the bilateral Huygens linear fissure, and bilateral symmetrical motor signal intensity in the bilateral development. These are the three signature of glutaric aciduria. T2 plus their hyperintensity may also involve the corpus stratum, in chronic glutaric aciduria, cerebral atrophy and the cortical development can cause can be seen, and that can lead to formation of subdural hematomas. Now, getting disease of inborn error of metabolism, there is a sulfide oxidase deficiency where catalyzes in this disease the oxidation of endogenous or exogenous sulfide is catalyzed to sulfate. Typically with frequency and lethargy. There is increased urinary excretion of sulfide and is sulfocysteine. Increased sulfide oxidase activity is found in cultured fibroblast and confirmed by genetic analysis. It can lead to rapid progression to brain destruction. Cavitary changes happen in the brain, as you can see here. There are multiple vacuoles that are formed in the bone. These are very poor composites. So if you have time, you can go through this article which describes the classical devastating metabolic disease in bones and friends. Now coming to LPCL, analytic point capability with brainstem and spinal cord It is again an autonomic recessive, slowly progressing cerebellar ataxia, spastic and dorsal column dysfunction, seen in first or second decade of life, caused by mutation of the mitochondrial aspartate RNA synthesis encoding gene located on chromosome 1q25.1. So these are the revised 2021 MRI criteria. We mentioned that major criteria include cerebral white matter, dorsal column and lateral corticospinal tract of spinal cord involvement. Pyramid at the level of medulla oblongata or dividation of the medial hemisphere both should be involved. Minor structures that should be considered are stadium of corticospinal posteriorly of internal capsules to cerebral peduncle, interventional part of trigeminal nerve, essentially trigeminal tracts, anterior spinal cerebellar tracts with medulla oblongata and cerebellar white matter. So as you can see, there is involvement of the cerebral white matter in the peripedicular region, which is pairing of the subcortical region. Then there is involvement of the dorsal columns and lateral corticospinal tract in the pyramid with the medulla, and as well as the dorsal column and the lateral corticospinal tract in the spinal cord. Again, you can see here there is involvement of the cerebellar peduncle as well as there is involvement of the interparenchymal part of the bilateral trigeminal nerves. Here you can see involvement of the cervical spinal cord. These are all features of this entity called LPSA. Now another devastating disease that is discussion is non-ketonic hyperglycemia in an which was an extremely thin corpus callosum, weighted and diffusion weighted disease shows striking diffusion restriction in the cerebellar white matter as well as the internal capsule. You can see alternate signal in the diffusion restriction in the central tegmental tract, but remember central tegmental tract hyperintensity has other causes like tegmental hypoxia, mitochondrial disorder, neuroradiological cholestasis, and symptomatic and featuring hydrogen transferase deficiency. So I have tried to summarize the stuff what I have gone through till now. So these are the soft pointers that you should remember. If you see macrocephaly, please consider Canavan, Alexander, MNC, as I have already discussed, or erythrohydroxyglutaric aciduria. Frontal predominance is most common in Alexander. Posterior predominance is most common in X-linked ALD. Cerebellar involvement is noted in juvenile Alexander cardiac LSBL. Cerebrotegmental dermatosis, L2 hydroxyglutaric aciduria, and MSUD. Cystic white matter changes are noted in fancy white matter due to megalocratic frequency sulfite oxidase deficiency, Alexander disease, hyperdecubitus syndrome. Intraparenchymal calcification can be noted in hyperdecubitus syndrome, Copeland syndrome, mitochondrial disease, ALD and PGIPS disease, dilated perimuscular polysaccharide syndrome, congenital muscular dystrophy. Enhancement is noted in ALD, Alexander or Claris disease. Infarcts can be noted in Wheeler's and Fabry's disease. Thalamic involvement is noted in cardiac amyloidosis and disease. Abnormal gradation can be noted in Zellweger syndrome and Neurosine deficiency syndrome. So now we will be briefly discussing the primary demyelinating disorders. So as we all know, the most common is pediatric MS. It's an immune-mediated disorder. Pediatric MS is now increasingly recognized in proportion patient diagnosed prior to age of 18. Epstein-Barr virus causes possibility deficiency and presence of inequality and alligator risk factor. They generally expect these children for results in clinical course. MR features are similar to adult. MR diagnosis children defined. So these are the clinical section, the dorsal center, which are calorecenter, bilateral cerebellar white matter, so it can also involve the posterior further structures like brainstem, midcerebellar, frontal cerebellar white matter, optic nerve, spinal cord, cerebellar cortex, and fiber can be involved. Brain lesions, contrast enhancement and diffusion restriction, while the concentration generally do not show enhancement or diffusion restriction. spinal cord lesions are very short segmental lesions, and generally it doesn't vertical volume, which is a very differentiating point from the neuromyelitis opticus victim liver, which involves long segment of spinal cord. Cervical cord is the most commonly involved. Coming to the optic nerve involvement, EPML that is already established. Any optic nerve is not required unless atypical symptoms are present. MRI is part of the rule of coordinated diagnosis. When optic neuritis is the first presentation, role of MRI is mainly as the brain for additional enhancement part of the intraorbital part of the right optic nerve, as you can see in the axial and the coronal images. Now, pediatric neuromyelitis optica spectrum, these have a lower tolerance than the adult. Mostly of the course, failure of abnormalities consistently NMOSD, aquaporin 4 antibody is generally rarely detected in pediatric ATM lesions with acute myelitis is less specific for pediatric treatment. MS relapse or adding on can show a similar feature, 45% of qualifications experience multiple retaliation can be present. Which will take aquaporin 4 antibody NMOSD. So these are the NMOSD spectrum disorder that we should consider our pediatric patient, and classical optic neuritis, nucleus myelitis, and NMOID seropositivity is required for diagnosis of pediatric NMOSD. The lesions are alien like can be like multiple sclerosis involving the subcortical or deep white matter. However, there is a tendency to involve the hypothalamus, thalamus, and the epidendral surface of the heart ventricle. As you can see here, there is involvement of the hypothalamus, there is involvement of the bilateral hypothalamus here, and there is involvement of the PGIPS gray matter in this image. The NMOSD brain lesions can show three types of enhancement. It can show a patchy enhancement with the blood margin, known as the cloud-like enhancement, which is relatively specific for pneumonia, as you can see here. Or it can show a pencil ependymmal enhancement, helps to further differentiate this condition from MS. As you can see here, this pattern of enhancement. And rarely it can show solid enhancement pattern, where it is difficult to distinguish from acute MS, as you can see in this. Spinal cord lesions, as I have already discussed, is generally long segment, which is not the central cord, sparing of the peripheral region. Sometimes it extends into the rostral extension can happen into the brainstem. It can show variable type of enhancement, more specific pattern of enhancement described in spinal cord and NMOSD lesions. Optic nerve lesions can be unilateral or bilateral. Increased signal is noted. Post-contrast enhancement is seen, but there is more involvement of the posterior part of the optic nerve with involvement of the long segment of optic nerve. As you can see here, there is post-contrast enhancement as the optic as well as the pre-chiasmatic part of the bilateral optic nerve. So these are some small pointers that can be remembered to differentiate between the NMO and the MS. The most important finding you should remember is the spinal cord imaging. NMO will be greater than 3 segments of vertical volume involvement, where MS is generally short segment and partial cord involvement. Coming to ARDEN, which is very important in the pediatric age group, it is generally seen as a response to viral infection or immunization. It happens generally up to 4 to 21 days after the onset. It is associated with anti-myelin oligonucleotide antibody in few cases. MRI shows multiple bilateral initial hyperexcitation. It can involve both gray and white, both gray and white matter can be involved, gray matter can be involved, pigment can be involved, because myelitis can be involved. These are the criteria that should be considered for diagnosis of ARDEN. Special which we can see the local ARDEN lesions. So you can see the examples of some brainstem lesions which can be remember what was that organ can be seen both all three of MS, NMO and ARDEN. maintaining MS is more frequently in the tissue and the body of the body that can interface, while in NMO it is more frequently in this area of the corpus callosum and it can while in ADEM it is originally at the peripheral multimeter present and not from the callus surface. So this ADEM, MS and NMO can overlap, as you can see from here, the physical features are overlapping. So it can contribute to the diagnosis. Now this is a recently identified entity that is the myelin oligonucleotide glycogen antibody activated disease. IgG antibody can be seen to the MOG protein, whereas clinical overlap with ADN and MOSV and MS. It is primarily encountered in children and young adults. MOG IgG is more commonly detected in children than appropriate antibodies. They are more likely to present with an ADEM-like clinical feature, while adults are more likely to present with an NMOSD-like sign. This clinical feature is similar to other acute debilitating features. Optic neuritis is the most common presentation, followed by transverse myelitis, then the ADEM-like encephalomyelitis, optical neuritis with seizures, and relatively clear hyperintension in forward. This clear hyperintension is referred to as flames. Clear hyperintension in anti-MOD associated encephalitis with seizure. Infant renal syndrome, that is because of spinocerebellar syndrome, occur and may present have a creeper like presentation. No brain lesion is pathognomonic of MOGAD. So just few short pointers to remember. Less than half of the adults presented with MOGAD have brain lesions at the time of diagnosis. Lesions tend to be few in number but visible, typically bilateral, ill-defined border, deep payment and brainstem involvement, more common in children, electromagnetic enhancement, uncommon but exposure, either transmission or along with cortical lesion. Parenchymal enhancement with brainstem, gray matter, white matter, vertigo involvement are also detected. This is a class case of the multifocal areas of imagination, some cortical enhancement. This is the case of overt imagination. Spinal cord lesions can be longitudinally extensive or short segment and both can happen together also. This category shows the involvement of gray matter of the H sign on axial view and the thick linear tubularitis on the sagittal view. Lower cord is often primarily affected, whereas medullaris is classically affected in overt spinal cord lesion. A helpful distinguishing feature is the presence of electromagnetic enhancement related to but rarely seen in multiple sclerosis and NMOSD. As you can see here, the typical H sign of overt spinal cord lesion. In overt optic nerve lesions are typically bilateral optic neuritis, but it involves anterior part of the optic nerve and posterior part as we have seen in NMOSD. So optic neuritis in the optic nerve sheath are also characteristic findings that may be orbital enhancement as well. Involvement of optic as an optic tract is uncommon. So you can see here bilateral optic nerves are folded with the perioptic neuritis, the perioptic sheath. There is a stranding around the optic nerve, the optic nerves appear to tortuous obstructions. Push pointers enhance the optic nerve and present the perioptic sheath. So these are some soft pointers to differentiate between the anti-MOG antibody. So remember, MOG generally involves the lower thoracic spinal cord, and the accompanying antibody is cervical predominant involvement, and the posterior optic nerve involved in the MOG spectrum, and MOGAD is the anterior optic nerve that is more commonly involved. So this has been an extensive talk, so I tried to cover as much as multiple disease as possible. It is very difficult to remember. I think you should go through this presentation repeatedly. Modalities pattern approach is very important for unresolved leukodystrophy. Nearly identical neuroimaging features are there, so it can be misleading. So it should be coded with the clinical features at the early stage of the disease. It is important to remember the some key points, particularly the soft pointers that I mentioned in the chart, and the demyelination disease generally is noted in little bit older children. Thank you all. Apologies once again for not being able to present. Hope all of you have enjoyed the talk.
So thank you, Dr. Nirmal, for a lovely presentation. It's a very brainstorming, and it has covered almost all the chapters of the parts of pediatric neurology. And these are most complex zone, the demyelinating diseases as well as various kind of neural migration diseases. So at the end, we distribute the workshop certificates. Some of them have left because it's a very long process. So I like to request Dr. Sujita Malaga to come on the stage. We will distribute it. And almost all the faculties have left. So Abdul Rahman is there? Please come. Next, Ovijit Roy. Please write your name and as a designation. Next, Abhishek Singh. Amrit Hajra.
साइड दिए जान
Anupam Mandal. Orko Gopal. Arnav Ghorai. Orpita Datto. Oyon De. Benazir Begum. Busra Aslam. Devanshu Boito. Dipankar Boshak. Ekta Pal. Himatri Shekhar Kisku. Himanshi Roy. Johar Iqbal. Kushal Banerjee. Mohammad Muqtadi Rahman. Mohammad Alamgir Alam. Meghna Pal. Nidhi Ranjan. Niveda Manna. Pamela Patnaik. Rajdeep Shah. Pratyusha Bag. Riya Ghosh. Sabir Ahmed Molla. Sanjay Pal. Then Shah Mossad Haidar. Samim Ahmed. Shantashri Ghosh. Somosri Panda. Saurabh Rai. Srijita Vishwas. Shubhasri Das. Please wait, we'll have a picture the last time. Just wait for 2 minutes. Saurabh Rai. Srijita Vishwas. Shubhasri Das. Sunil Hembram. Suparna Haldar. Trishita Bosak. Rokia. Soumitra Matani. Then Subhashish Haldar. Nikhil Gupta. Ornisha Mondol. Pratoti Saha. Orijit Singh. Syed Muhammad Saeed. And if anyone left, please come and collect the certificate. Now I like to hand over the certificate to our faculty. Yes. I like to hand over the faculty certificate for participation to Dr. Sujita Malaga. Thank you, ma'am. You have been with us throughout the day. Thank you very much. And also, please take the certificate of Dr. Nirmal. So, we'll take a photo. Please all
So you're going to make our work easier. Our juniors are lucky that you will not disturb them for everything at night, and they can sleep peacefully on their emergency duties.
दादा हाथ चले আসছে একটু সাইডে বাস ঠিক আছে একদম
So the workshop ends, and we are expecting all tomorrows in our scientific sessions. Thank you.